So let me welcome you all to MS Views and News, first program ever in the state of Illinois. Thank you. For those that do not know, my name is Stuart Schlossman, but you probably do because you got to see this wonderful thing behind me. All right, and yes, I too have multiple sclerosis, and again, you did hear that story, so I'm not needing to get into all of this. MS Views and News you heard about as well, but it's my passion to do what it is that I am doing, sacrificing many of the things that I could be doing on weekends or during the week to be able to provide for the many that I know that need to learn from programs such as this, where it's an A to Z of all the MS FDA-approved medications, as well as things that are emerging and what could be happening in the near future. So we want to educate you on all of this. The reason for video recording these programs is a few things, one of which you have MS and you're not going to remember everything that's happening here today. So when we publish this program, you'll be able to go online and say, yes, I needed to remember something that was on there. Let me go listen to this again. Or yes, I want to show this to family and friends. Or yes, I just want to know that there are people in far-off lands, Indiana, yeah, far away, right? New York, Florida, Europe, Asia, wherever, they are going to have access to the information that we put up. Almost every one of our educational programs is video recorded, and we do this again so that way, number one, it is an enduring material, you can go back to it, and number two, that the people who are in areas that we cannot do programs can still have this accessibility to the knowledge that's going to be provided here today and at previous programs. Last year, over 10,000 people watched our programs on the YouTube channel. Last year, on average, our website and our blog were viewed in excess of 100,000 times per month. These are what they call unique views. It comes in as a new thing each time. And again, the reason is we're just wanting to provide information and education via the internet. And this is what we do. So remember, everything you hear today is going to be a word that a lot of you only know from going to some religious facility. It will be inscribed, okay? It'll be inscribed for the future, for your children, grandchildren, or whoever else to see. Before I go further, I want to thank those that made it possible to do today's program. We rely on the pharmaceutical industry to be able to do our educational programs, and the pharmaceutical industry is quite helpful for us to be able to provide this, and they want you all to be able to learn all the aspects about multiple sclerosis. And so today, I want to thank Genzyme, a Sanofi company, for giving us the educational grant to do today's program. Thank you, Genzyme. Also at today's program, we have exhibitors. And those are exhibiting sponsors that, again, their dollars help us to be able to do these kinds of programs. And so we want to thank Novartis, who makes Gilenya. Some of you are on Gilenya. Teva has Copaxone, the 40-milligram formula that you only have to do 3 times a week. Okay? Accorda Therapeutics makes Ampero, the walking pill. All right? And Mallinckrodt, formerly known as Questcor, who has Acthar gel for those with different versions of MS relapse who cannot use a Solu-Medrol. Well, Acthar is available for you, and you just have to know about it to be able to use it. So, and again, we had Genzyme as exhibiting as well, and so I do want to thank all of them, our volunteers, our support group leaders, and of course, more than anybody else that I have to thank for today's program are all of you, because you're here, and we cannot do this program unless you were here today. So I thank you. Today's program format, we're going to have Dr. Wynn speak first, then Cathy Meyer is going to speak. Dr. Wynn, for those that don't know, there is an agenda on all your tables, so you can actually see what they're going to be speaking about. And then if they say anything else, well, that's just added to the program. And then we're going to have Cathy Meyer speak, and also, again, the Q&A. Remember to wait, please, until they both finish speaking. Before we ask either one of them to come up, though, I'm going to ask all the support group leaders that are here today that we spoke with previously to please come forward, because whenever we're in a new climate, a new area, we ask support group leaders to get involved with our programs. We ask them to speak for 90 seconds each. And so I know there are 5 or 6 of you here today, but I only see up 2 standing now. Where are the others? Come on up, all right? So, although MS Views and News does not do support groups, once upon a time I was a support group leader. I co-facilitated a group for 10 years down in Miami. So I know the importance of these support groups. Whoever cannot come up, don't come on up, don't come up. We'll just have you over here. At your turns, at your turns, at your turns, at your turns. First, we're going to start with this gentleman. Explain yourself. You got 90 seconds, then you get the hook.
Oh, 90 seconds. Okay. First, I want to thank MS Views and News for putting this program on. This is a great thing. And second, I'm the new facilitator for the Algonquin MS group, which meets in Algonquin, Illinois. And we're right off of Pyatt Road and Route 62. It's at the fire station. We're in the lower level, but they do have an elevator there, so anybody that needs an elevator, it's available. And anybody with MS or friends and family of people with MS are welcome to come to the meetings. We meet on the 4th Saturday of the month. It starts at 9:30. And we usually have a guest speaker for every meeting that we have. And let me see. And then we also have partners on the Journey group, which are, people that help people with MS and their family, and they meet separately. They usually break out for about 45 minutes and do their thing. And we don't ask you to do anything. The amount of participation you want to do is up to you. And our next meeting will be the next Saturday, April 25th. And we're having a sleep specialist, Dr. Keller, come and speak for people that are having sleep problems. So yeah, I think that's about it.
Great.
So, all right.
Thank you.
All right.
Thank you. Thank you. You don't get to Kindle. No, you don't get that. Next, come on. Do you want to come up or do you want to stay down? You're going to come on up. Okay, come on over here.
Okay.
And just tell us your name and what you do for the group.
Okay. My name is Jean Young. I'm from Downers Grove, Illinois. We have a group there for people in Downers Grove area and Naperville. And we meet the first Monday of the month, and we try to have programs that are of interest to people and will help them with their MS. And we have social time, and I didn't write this down because I thought I might forget to bring it anyway. So that's about it at the moment. I've had MS since 1984, and fortunately for me, I had a drug that worked for me because I wasn't doing very well. So that's about all for the time being. Thank you very much.
Thank you. Thank you. Okay. Are you all staying down or you just come on up as well? Okay, so there we go. I wish we had a holder for you, but we don't. Have to remember that the next time. You got that, Bill?
Hi, I'm Diane. I'm the facilitator of the Elk Grove Village MS Support Group in Elk Grove Village. Our group is unique in that we actually meet during the day at 10 a.m. on the 3rd Wednesday of each month at the Elk Grove Village Library. The MS has brought us together, but it's also keeping us together as a group to lend support to each other, regardless that our MS symptoms or issues and the level of MS that we have is so different from each other. Every month, we gather together to discuss MS issues and everyday issues that may impact our daily lives. This month included a meeting on Social Security and how any negative adjustment to Social Security could impact our lives. This coming month is May 20th's meeting, and we're going to be having a speaker, Joy Wagner. But we like to have fun too. Actually, in October, we're celebrating our 20th year as a MS support group. And every October's anniversary meeting, we meet at a restaurant for breakfast at an Elk Grove Village restaurant. So I hope you don't forget, if you want to come to an MS group meeting, we meet during the day at 10 a.m. at the Elk Grove Village Library.
Thank you.
Hi, I'm Linda, and I run the Forest Parks support group, and we have an active support group. We take new members, we take old members, we take family members. We're not prejudiced. We'll take anybody who wants to come. We meet once a month, the first Monday of the month, but it's at night, 7 to 9 p.m., and we do serve refreshments. We may have homemade cookies or cupcakes. We have coffee, we have iced tea. So come on down, join us. We do get speakers every other month, and but more than anything, everybody is welcome.
Need a hand?
Thank you. Oh, I always like a hand. Tell me where.
Right there.
Okay. Hi, my name is Shar, and I am the facilitator at the Elgin Support Group in Elgin, Illinois. We have a different kind of group. We meet every 3 months. We do not meet in January or February because it's too cold. We have too many snow days, and it's a real bummer to try to plod through the snow when you have a walker, a cane, a scooter. So we meet in March, and then we don't meet again until June. We don't meet in July and August because it's too hot, and we know what the heat does for us, right? So we try to take this into consideration. And then we meet in September, and then we have a holiday party around the end of November. We have several men as well as women in our group. I know they say that men with MS is more of a rarity, but I don't know, Elgin got lucky and we have a lot of men there. So we, every once in a while, have a caregivers meeting so that the caregivers can sit down and grouch about what a pain in the butt we are to them. And I think it helps them vent. And they need that as much as we need the help to vent also. Our meetings, like I say, are the third Tuesday of the month of March, June, September, and then at the end of November. My number is listed in the MS computer, okay, online. You can get our numbers. And we look forward to anybody who wants to come and join us. Thank you.
Thank you. Thank you, thank you. I'm gonna go that way. All right, next up we have Mike. I could say Mike by name because I know him a long time. Mike's been following a lot of Stu's Views and MS News for a long time, and he's one of the reasons why we came to Chicago. So I want to thank Mike for having us do this. Thank you.
My name is Mike Kubanek. I am from the Orland Park, or South Suburb Support Help Group. We are one of the larger groups in the state of Illinois. I think our last final count of members was 207. So we have a pretty large group. We're pretty dedicated to doing whatever we can to cure MS. And we come together. We also have speakers. We have our group with MS, we don't say we have MS, we have mighty stomachs, because we have cooks in our group that bring something every meeting. We meet every second Thursday of the month. We also have a Facebook page. You can look it up on Facebook, South Cook MS. And they'll give you the listings and whatever's coming up and whoever having as a speaker, because we have Dr. Reeder, I think we've had Dr. Wynn come. We've had Amy Ross Perrin come. We have a Tai Chi class coming up, which is kind of different. And then we had a music, a teacher who would do music and he'd help you with the MS. Learning how to play, and they give you the drums and the tambourines. And it just took your mind away for what you were playing. But we do a lot of different stuff. I mean, we do quite a bit. We have a lot of fundraisers. We do bowling. We also do skydive for MS. We have a bunch. So take and look us up on Facebook. You'll enjoy it. Thank you.
So my thanks to all the support group leaders, because you all have a really great purpose to do for those that are your constituents in the community. And I applaud all of you for what you are doing, and I hope that everybody can learn from what you're doing at your groups. And if you know somebody that doesn't attend a group, you really need to tell them why they should be there. I mean, you're there for a reason, right? So there is a reason why the others should be there as well. Without any further ado, I know that you guys are like dying for me to get this thing started already, so we have, again, Dr. Wynn's going to come on up, and I'll ask him to come on up. Thank you.
Thanks very much for everyone being here. I know that many of you have been to a lot of programs before, but I suspect there are a lot of people in the room who, like me, were terribly inspired by people on the stage. Stu, who's really been a presence for people, not just near where he lives, the support group he ran in Miami, but now forming Stu's views so that we can keep up with these things every single week. So having a program like this, I know you put your hands together with me. We're thanking Stu for making these kinds of things possible. And really, thanks for inviting him up here. I think that was a tremendous idea. But here in our area, where we're most dedicated, to have a series of people who make it what they do, to put themselves out and be bold and run support groups, to me, these people to me are champions in our community. So I really want to put out my heart to them and make you all know that as Cathy and I are dedicated to each one of you as well, we want to support you in the support group leader function as well, and to support you in doing that and make ourselves available to you as well. So I'm very, very excited to be here today to talk about different aspects of multiple sclerosis with you. And I know after I speak, after Cathy Meyer speaks, we'll have lots of time for question and answer as well. But again, really, I couldn't be more pleased to share the stage with such a wonderful group of people. The title I made for a talk years ago was this title, Imagine. Imagine a world without MS. And that's really what we're here to do. We're really here to figure out a way to have this disease go away. I think a lot of people can think back to when someone was sitting across from a table, a doctor or a nurse, and said those horrible words. I'm sorry, I think you have MS. And I know many of you in the room can remember that, and your heart sank, and your mind said, uh-oh, one day I might not be able to do X. We're here simply to be your X factor, so you always get to do X. People sometimes say, what should my goals be if I have MS? It should be the same goals as before you ever heard about MS. And if you need help, doing a workaround, that's where each one of us is for everyone else, to help each other and do that. So again, thank you for being with us to talk about this a little bit today. I've specifically been asked kindly by Stu to talk about research and treatments in multiple sclerosis. As many of you know, it's just really skyrocketing. I mean, 25 years ago, there was one drug for MS, ACTH, a drug to treat relapses. Solumedrol wasn't available even then. Now there are 12 disease-modifying therapies, soon to be more. 3 literally got added last year. Each year there are 2 large meetings for neurologists, the fall meetings in Europe, the spring ones in North America. This year, the American Academy of Neurology meeting begins today in Washington, D.C. And actually, that's where my suitcase is sitting up front, because that's where we're going right after this meeting. So again, this will just be the tip. Next week, I'll have a lot more information we'll be able to share. I think a lot of people ask if their doctor or nurse recommends they go on a therapy, well, what can these drugs do? Do they bring my blood pressure down? Because we don't have a marker like blood pressure or cholesterol level in MS. So what do the drugs do? I think certainly when the original therapies were all injectables, most shots that one takes do what? They relieve some sort of suffering. If you have pain, you get a pain shot, the pain goes away. But when you start a medication for MS, you want to ask, what does this drug do? Does it make MS better? Does it reverse MS? Not yet, that's coming. What we look at in each of the clinical trials are the 3 main parameters that occurs in the disease. MS is the prototypical inflammatory disease of the spinal cord and brain. So what you get is, of course, as you know, is areas of inflammation in the brain and spinal cord, spots on the MRI scan, lesions, scars in the brain. When those scars happen in a bad spot, you get a symptom.
A relapse, a flare-up, exacerbation, a new or worsening symptom lasting more than 24 hours in the absence of a fever, cold, or flu, or something like that. Or having a support group meeting in August where it's too darn hot, like we heard about a moment ago. But do all relapses always go away? Do all relapses go away? Unfortunately not. Otherwise, it'd be very easy to tell from looking around the room who's having a flare-up, because everyone else would look totally normal. And the relapses we like the least are the ones that don't go away. Also, we like to stop the disease early in its tracks. The National MS Society recommended, 20 years ago or so, that people get started on disease-modifying therapy as soon as a diagnosis of MS is made. Or even now, when there's been one episode and findings on MRI scan consistent with MS, meaning as few as 2 lesions. And why is that? Because the studies of all the different therapies have shown the earlier the therapies start, the more effective they are. Or the way I've often put it is, how we set the table for the first 10 years is what you eat for the next 20. And some of you can look back at how that was for you. I know when I worked at the Mayo Clinic, I worked at the Mayo Clinic for many years. I've been involved in the clinical trials for all the drugs in the market pretty much, plus some which may come yet, some which you won't hear about because not every trial has always worked. But years ago, a lot of individuals would come to Mayo Clinic to find out if they had MS. And before there were therapies, it was not that rare that people would not even tell the patient. Like, don't tell her, she'll get depressed. Like, we talked to the family, but they didn't talk to the person with the disease. So now that there are therapies, hopefully that ancient practice is really gone for good. When the therapies first became available, we could get them initially, but then we'd get 1 of 2 letters from an insurance company. She's too mild, she doesn't warrant the medication yet, or it's too late, don't deserve them. That made it easy for insurance industry because they didn't give it to anybody. So some of our patients actually filed lawsuits, and that changed the way that some of the insurance companies work. So as you advocate for each other in your support groups, we help you facilitate that as well because it makes us miserable as well. So the drugs do not reverse MS. So if you had a flare, it didn't go away. If you started disease-modifying therapy, that symptom is not necessarily going to get better because of that drug. There are 2 ways to be your doctor the old-fashioned way. When you do poorly, remind you have a terrible illness. But if you get better, to sit back and take the credit. Our job is to not do that. That's just grossly dishonest in my opinion. If you do well, I give you the credit because you're the one doing the hard work. I'm not taking the pill or the shot or the IV. You are. If you don't do well, we'll work harder. It's simple. I know we have more paperwork maybe than you do, but I know you do all my paperwork for me if I would just get the MS for you instead. That would be easier. So again, what do MS therapies do? Multiple sclerosis simply means multiple scars, like those spots you see on MRI scan. Many of them do come and go, but some come and stay. And if you have a particularly destructive one, certain things are not happening anymore. Maybe you're not using your hand to write. Maybe you can't see out of the eye, or this leg's awfully wet feeling. It's like, doesn't look wet, but it feels that way, or something like that. Present MS therapies don't make one feel better. It makes you feel better that you're taking care of yourself, you're preventing another episode, but in the same way, blood pressure medications don't completely prevent people from having a stroke in the future, a heart attack in the future, otherwise no one would have heart attacks in America. What we want is to prevent further loss of nerve cells in the brain. There are a lot of therapies we have in trial right now which help stimulate myelin regrowth. We have a few of those. I'll mention some of those. And there are drugs we have which help damaged nerves conduct impulses. So one of the medications I saw displayed out there, Empira, I was thinking about it. One of the women I take care of, she's the director of marketing for Universal Studios. And as many of you know, J.K. Rowling, the woman who wrote the Harry Potter books, her mother had MS. So she asked, so everyone knows Universal Studios that opened up the new Harry Potter theme park last year. So she asked me, could Harry Potter help us with MS? I said, absolutely. I want the wand that goes, MS, go away. She said, we don't have that one yet. We're working on that for the next theme park. How about myelin grow back? We have some of those medications in trial. But what about a medication that would make nerves conduct more effectively that have lost some of their myelin? That's kind of what the magic that Empira is. So for those of you who haven't heard about that or talked to people about that, please talk to others about that. It's a very effective therapy for many people. And again, I'm particularly proud of it because a lot of the very early work on it, going back more than 20 years, was here in Chicago. What's the best treatment for any MS relapse? Don't get it in the first place. Now, it's confusing. Like, why do people with MS not take therapy sometimes? It's because MS is more common in women than in men, and it's a lot more common in Caucasians. And in Caucasian women, early in the disease, most symptoms are sensory, numbness or tingling, and or optic neuritis, loss of vision, a sensory symptom of the eye. And they often go away. Early relapses often resolve, if not completely, largely. And so it sort of looks like, well, why do I have to take this medicine? Or actually, I joke because my daughters work in Southern California in Los Angeles. It's easy to be a doctor in Los Angeles. They have medicines there. Here in the Midwest, we just have drugs, and of course, we don't want to take drugs. But early disease, there's the visible symptoms of MS, as Cathy will talk about, but they're the invisible ones. The visible ones are someone noticed you have a brace on your leg or on your hand. But they're the invisible ones. Like your husband had to remind you 9 times the meeting was at the Marriott Chicago. Or that your foot's on fire. Or you look, how could you have MS? You look so good. Well, thanks for saying that. I'm blind in both eyes and I can't stand up. But you look great too, even though I can't see you. If I could, maybe I would disagree. So what we want to do, the best treatment for MS is to prevent it from coming, to stop it in its tracks, to make MS quiet, and to one day make MS history. In MS, I don't know if any, probably I guess if you have MS, they switched this to HD, sorry, the print got small. We have what we call the 3 MSCTers. There are 3 arms of treating MS, right? So on the left, they're the disease-modifying therapies, and I'll talk about these. The multiple injectable ones, the interferons, Rebif, Betaserin, Extavia, Avonex, Plegridy. A non-interferon injectable, Copaxone. 3 IV drugs, Novantrone, Mitoxantrone, Tysabri, and we're the largest site also in developing that medication. And most recently approved last year, the end of last year, Lemtrada, a drug given just once a year and not even every year. And now 3 oral medications, Gilenya, Aubagio. If you can't remember that name, that's the one that sounds like a casino, Aubagio. For about a month, it was a cheese, but I like the casino analogy better. It's not a gamble to take that drug, though. I'll tell you, they have 3 trials in the package insert involving several thousand people. And each trial in MS, it slowed down disability. I wish I could say that for the other 80-plus MS studies I've been involved in. Many of the disease-modifying therapies presently on the market, in each trial did not slow disability. So there are 12 medicines. So part of it is finding disease-modifying therapy that works for you. A woman who was new to see me, just moved from Long Island, New York, asked me, well, how aggressive am I and which drug do I give everybody? I said, I really go through them with every person who comes in and describe the pros and cons. I mean, I can tell you what everyone has on their brochure. One you get to do parasailing, one walk along the beach or something like that. Remember, one day it might not be able to do X. If you pick the drug that just had the best brochure, but one day you can't do X, that it had the best brochure might not be consoling. So we like people to come to view Stu's site, to go to support groups, to learn more of the data. What's the science behind this? How well is this really going to work? Is there strong science behind this? Or is it just like, they got another drug, but it's got a great brochure. You should try this one. Some people, the main thing they want in a drug is it says new somewhere on the brochure. Don't have new be the primary reason why you take it. Because I still see people, it's like, I've already taken 10 of them. It's like that person may have needed a solid conversation with someone to help them pick one rationally. Now, they haven't found the cure for MS. I learned that because I looked on Stu's site just yesterday. And because there is no cure yet for MS, in relapsing MS, here's the bad news, okay? Relapses still happen. So it's key that we have therapies for MS relapses. The therapies for MS relapses simply make them go away quicker. One woman who came to see me yesterday, her right foot is completely numb. She moves it pretty well, but it's numb. What's one thing you can't do if your right foot's numb? You're not supposed to drive. So actually, she mentioned that to me. You know, I want this to get better because I want to be able to drive. I said, you're not driving now, are you? She goes, no, and I saw her then drive away. She lives north, don't worry, she doesn't live out here. So not all flare-ups require treatment. We recommend therapy if it's disabling. But many people do because, like, inflammation in the brain is like a fire. Do they think we want to put the fire out to get that inflammation down to get the disease under better control? But the other aspect of treating relapses is this. The other aspect of using disease-modifying therapy is this. Some people say, well, I'm not getting worse. I walk as well as last year. I haven't noted a relapse. Again, a relapse, a new or worsening symptom lasting more than a day or two. What's one of the problems with that definition? Well, maybe I'm just really depressed for 3 weeks in a weird way, or I'm cranky in a way that Cathy didn't notice. Or I'm like crying at things that aren't necessarily sad, like TV commercials with dogs in it. The Blackhawks game that did make me cry, that's another thing. That was normal. So some flare-ups are easy to recognize. If you couldn't see out of your eye, you got numb up to the waist, it's going to get your attention. But if your mood has changed for a couple of weeks, you're having more trouble remembering things, that's something different. Now, what is it, though, that really makes people with MS better? And if people know me for one thing, it's not that I've been involved in over 80 of the multi-center clinical trials, not that I help run the clinical trials for many of the companies for them, not that we're one of the largest MS centers in the Midwest. It's just that to me, the part of treating MS I like the most is providing good symptomatic management. I mean, if you have MS, it doesn't mean you have to be like on like American Airlines, every hour on the hour you're out. You got to go. You know, you don't have to go to the bathroom the rest of your life every 30 minutes. You don't have to have painful feet. You don't have to have depression. This is America. We have more medicines for mood than antibiotics, I think. You know, there are medications for fatigue. There are medications to help you walk. There are medications that keep that funny crying thing and make it go away that aren't antidepressants. There are lots of good symptomatic managements, and I'm not going to talk about that because the better half of our MS center, Cathy, she's going to talk about that a lot, and I know you'll give her a great listing. If you don't, we have a drug for that. Now, as I mentioned, part of the MS tears is treating a flare-up. And the very first therapy was ACTH. Some of you know I worked at the Mayo Clinic in Rochester, Minnesota for many years, and there's not a lot to do in Rochester, Minnesota. I mean, I did build a Walmart since I left there years ago. But back then, there were like a few stoplights and one grocery store. They opened up a second grocery store while I was there. That was nice. So there's not a lot to do there other than work and memorize little Mayo Clinic factoids. One of them is that led to a Nobel Prize. It was around 1940, Dr. Kendall won the Nobel Prize for synthesizing cortisol, the natural stress hormone our body makes. But in 1940, was there the technology to make prednisone pills or IV Medrol? No, there wasn't. So that was like a huge drag at best. But it was known there's a chemical our body makes, a natural chemical made in our body called ACTH, that stimulates the adrenal glands to make steroid, the natural stress hormone, cortisol. And so the Mayo Clinic in Minnesota is in farm country. Two kinds of farms mostly, corn and hogs. And you've heard the saying, they get everything out of the pig except the squeak. They just harvest the ACTH from the pig. They have a special farm, I think, in Canada now where the pigs come from. I've asked, I think they use the rest of the pig for Canadian bacon, but I have no confirmation on that, so don't quote me. Now, flare-ups are scary. And people ask me often, how long will it take to work? My favorite medication in the world, a cough drop. In 5 minutes, I know one of two things. Cough's gone or I took the wrong cough drop. The drugs for relapses don't work that quick. So one study I'd like to show is a study that was done years ago in optic neuritis of ACTH. Again, at 2 weeks, at 15 days, 20% of people who had placebo had some change, but already about 3/4 of individuals, 76% of individuals on ACTH had clear improvement in their vision. At a month, a little more than half had some change who were on placebo, on inactive substance, but well over 90% of people with optic neuritis who got ACTH got better. So got a numb foot, you can't drive. If you can't see, please don't drive either. Now, it's true that optic neuritis often does get better, but it might get better slowly. 95% of individuals with optic neuritis will completely resolve at the end of the year, by the end of the year, if you just wait without a treatment. But what's the problem with that statistic? What happens to the other 5% of people? They've got a blind eye. That could be a problem. So there are trials in other types of MS relapses as well. Optic neuritis is an easy one to study because we have easy ways to measure it. Like if we were doing a study of my leg was numb relapse, how do we have different doctors assess that? But optic neuritis, we just measure visual acuity, color vision, contrast sensitivity. It's easier to measure. So as I mentioned before, there are multiple therapies for MS. There are the different injectables. Copaxone, the most widely used therapy for MS, even with a dozen in the market. Well over 30% people take this medication. Copaxone was originally studied in the 1960s. The original study of this medication was to try to actually create a drug that would cause an animal model of MS. That study, fortunately, failed. It didn't cause an animal model of MS. It blocked it. That later led to studies in humans. Copaxone, as you know, is just a polymer of 4 naturally occurring amino acids. Glutaminyl acetate, GLAT, glutamic acid, lysine, alanine, tyrosine, like the food they put on your table. So some people say, well, what about natural therapy? ACTH is a natural drug. Our body makes that. The amino acids, that's natural. But the way that this company makes it is very highly specific. There is a generic copy of it that, was recommended for approval recently, and I recommend the generic one if you have generic MS. But I'd like to see a study giving that to humans first, because having been involved in helping run studies for Teva for years, even some of the ways that they tried to change it in the past didn't work either. The group in Mexico City at one of the recent meetings presented their data on using a generic Copaxone in Mexico. And the number of hospitalizations for MS, when people started getting the generic Copaxone, more than doubled. So that's pretty bad. They're the interferons. The interferons are the first medications FDA approved for MS. The first one was beta-seron, which is sold under 2 names, also as Extavia. Rebif, Adherence, and the newer one, Plegridy. And these clearly also are effective at decreasing new MRI lesions, relapses, and some in slowing disability as well. Interferon also, in some senses, is a natural substance. Rebif, Adherence, this is interferon beta-1A. It's a chemical our body makes. The chemical probably predates the evolution of humans by tens of millions of years. It wasn't that myself or the people in Chicago or someone else was so brilliant we thought, well, we'll just give interferon. It's a chemical that slows inflammation in the body, like in the brain, but also fights viruses. Every now and then someone says to me, well, interferon ruined my liver. The most common use of interferon, not beta interferon, but alpha interferon, isn't to treat MS, it's to treat hepatitis. If interferons ruin livers, we would obviously not be able to use alpha interferon for hepatitis. We did a study of alpha interferon in MS. It also was effective, but had some side effects that the beta interferons don't have, which is why it's not used. Now, as I mentioned, there are IV therapies. The first one that got approved 15 years ago was novantrone mitoxantrone. It's an IV therapy given every 3 months, but a maximum number of doses can be given, around 8 to 12. In people with progressive MS, though, it clearly has a very strong effect. It's used rarely now because we worry that a rare number of people could get congestive heart failure. A rare number of people might get leukemia from that medication, so that's why the drug is rarely used. But it is the cheapest, just to let you know. I mean, a whole year's worth of that drug costs about a fourth of 1 syringe of Plegridy, just to put it in perspective. Tysabri, we're the largest site again in the Tysabri trial. The brought drug to market. It's a once-a-month drug, and it clearly decreases MRI lesions, relapses, and slows disability, but mostly in younger individuals. In the phase 2 trial, Bowel included people with secondary progressive MS with relapses, but unfortunately that population had no effect. Does that mean people don't use it in that population? No, it doesn't mean that. But again, before I pick a therapy myself, I'd like to know, were the people in this trial for this drug you wanted to give me, doctor, are those individuals like me, or is it someone who was newly diagnosed? Because the greatest effect of that trial was in men under 30, women under 40. There is an ongoing trial of Tysabri in secondary progressive MS, the results of which one day we'll know. Lemtrada was approved most recently in November last year, but more than a year, well over a year before that in pretty much every other country in the world where the drugs are approved, like many countries, dozens of countries. It's a drug given once a year. We give it in the office 5 days in a row the first year, 3 days in a row the next year. Then for over 80% of people, that's all the medicine you're going to need for more than 5 years. Now, why was there the slow approval in the United States? There are several reasons, but one of them is this. You have to get a blood test and a urine test every month for 4 years after your last dose of that drug. And the FDA was concerned about this. What if you lost your insurance? Would you still get the blood work? So what the company did is they bundled the cost of all that lab work into the cost of the drug. That's true if you have insurance, no insurance, or in government health insurance, Medicare, Medicaid. The cost of the labs are all included in that. So you don't have to worry. Once you've gotten the drugs, you can get all that lab work, for years. So that was a huge benefit. Now, the other thing in the Lemtrada trial that was very exciting was this. I've been telling people the medications that we have for MS, they decrease MRI lesions, decrease number of flare-ups, and slow down the progression of physical disability. But even I'm smart enough to realize that when I say it slows down the progression of disability, that's not what you're really hoping for. It's kind of like, we'll slow down your death from pneumonia. You want to get better. And interestingly, in the Lemtrada trial, the average person did improve. It's the only medication on the market that happened. Now, the magnitude of improvement was not great because some people in the trial did not have that advanced disease. But again, if you haven't heard about this one, I would learn about that one. The drug hasn't been out for 6 months. They're not allowed to talk about it in patient programming and promotional programs, so to speak, for 6 months. But this is not their program. This is Stu's program and your program. Now, when the very first therapy came out 24, 25 years ago, beta-serin, people were excited. I was on WGN radio, a Bob Collins radio show. He was a patient of mine for another condition, and he had been on a show several times talking about it because the drug was approved in April but wasn't available till early fall, some of you may remember. And so we did a program talking about what is this, and people came in to hear about interferon because they got gray, were some of you turned gray when you heard the diagnosis? Kind of scary. Then finally there's a drug. Oh, very good. Is it a green pill or a yellow pill? It's a shot. Well, that was scary. So we have oral medications too. The first one that was approved well over 4 years ago was Gilenya, which has been taken around the world by well over 100,000 individuals, more than 10,000 in one of the numerous clinical trials of the drug. The second one was Aubagio. Aubagio, the generic name for that is teriflunomide. Teriflunomide is really a reworked drug that's been on the market since the 1990s for treating rheumatoid arthritis. The drug for rheumatoid arthritis has to go through multiple extensive processing in the liver, but teriflunomide, Aubagio, is the active chemical that works for MS. So by giving Aubagio, we show it has a strong effect on MRI, relapses, and again, each of the trials of the drug had a strong effect of slowing disability. But here's another thing that differentiated that trial from every trial except the trial of the chemotherapy drug Novantrone. They included almost 10% of individuals in the trial who had progressive MS. Even including 9–10% of people with progressive MS, over 80% of people in that trial, the 10% trial, did not have progression. So to me, that was, and by the way, did I say it's a pill? That's really nice. The last pill that got approved, and it was approved actually on my birthday a couple of years ago, so now people from Bowel know what my birthday is, was Tecfidera. Tecfidera is a reworked psoriasis drug, and it's dimethyl fumarate in capsule, taken twice a day. The key thing is learning how to take the medication to minimize side effects from the medication. When we did the trial, people had a month to get up to the full dose. They couldn't get up to the full dose. They would be removed as a protocol violator. Unfortunately, 20% of people couldn't actually tolerate it for the first month, and actually 30% quit in the first year, largely because of GI, side effects, nausea, or diarrhea. Not everyone gets those. One of my patients told me she couldn't drive actually the first month on it. I said, why couldn't you drive? She goes, I couldn't get out of the car fast enough to go to the bathroom. So she just joked it was recommended by the Dry Cleaners Association of America. It is an effective therapy. You know, it's important that we have therapies for different individuals. Now, I'm glad that this slide is impossible to read because it just lists the drugs in the market for MS and when they came on. When there was one drug, this slide was easy to read because we could put it in big print. But now we have all these drugs that I talked about here, but then we have other ones over here. Lemtrada, Plegridy, and Copaxone 3 times a week were approved last year. But on the top, you see a drug called liquidomode. We've been using liquidomode for more than 7 years in trials of relapsing MS. And it showed us the results of the first liquidomode trial, Allegro, were interesting, but a little confusing and simultaneously. We were at the investigators meeting, and the drug had, you know, an effect on relapses, better than certain drugs, not as well as one. It had an effect, but its effect on MRI scan was pretty small, but its effect on disability was the biggest. So that's sort of confusing because all the drugs that are presently approved work primarily by decreasing inflammation. But this drug has least effect on MRI scan, a modest effect on relapses, more than some, less than others, but it has huge effect in slowing disability. We're one of a few sites in the world that did a special kind of MRI scan, MRI spectroscopy. And one of the things we saw is that myelin regrowth. So certain nerves get inflamed, and some will die from the inflammation. This seemed to decrease that hit rate, where the nerves would be inflamed, but then they'd come back, just bounce back, is a simplistic way of putting it. On the bottom is ocrelizumab. Another one that I could have put on there is ofatumumab. These are drugs that target CD20 B cells, the drugs that make antibodies. These drugs are extraordinarily effective at MS. You know, we're looking at maybe another, 1.5, 2 years before that drug, will go to the FDA. We'll find out about the ocrelizumab phase 3 trials. We're doing those that are starting the OPERA trials later this year. Again, very effective. It's a drug. That drug is given twice a year. And then daclizumab, the last one, the American Academy of Neurology, when it was in Chicago last, we presented the phase 2 data. I was the lead author for that. So, it was at McCormick Place, this mega amphitheater. There are more than 10,000 people watching. So not everyone could sit close enough to see me, so they had me on the big screen. So you've heard that saying, there's ugly and then there's like HD ugly? Neurologists were not designed to be on big screens. Sorry. But the data was really positive. The reason why it was in the big meeting is we saw that the chemical that drug works on is overexpressed in people with MS. We showed that in a separate genetic study. But also this drug works on that and blocks that, had a positive effect in MS. And that drug is given once a month. The rights to that drug were bought from the company that we worked for to develop it, between two companies, Biogen and our local company, Abbott, now AbbVie. But again, the main thing to notice on the slide, just take one thing away on the slide, there are a lot of boxes. 25 years ago, the slide had no boxes. 24 years ago, it had one box. The boxes are expanding. And now, when one of the drugs was approved last year, Cathy said, "You're acting kind of cranky. What's wrong with you?" And I said, "I'm acting cranky." She said, "Not your usual cranky either." So I said, "I don't know. I thought I was always cranky." So I went in the back and I sat down at my desk and I said, "Okay, that last pill got approved. Why would I be mad that that got approved?" And I realized I had this funny idea in my head that the FDA would only approve a medication if it's better than the previous ones. That's obviously as ridiculous as they'd only allow another cola if it was better than Coke or Pepsi. So it's important to recognize these therapies are very different. How effective they are is very different. How effective they are in relapsing versus progressive MS is very different. The side effects are extremely different. The safety is tremendously different. So, you can look at the brochures, but that would be like me trying to fix my car. I could go on the internet. Does Stu, do you have an auto shop site too? If Stu did one for a car, I would be able to fix my car. But my previous car was 18 years old, a little over 18 years old. And what's the secret of having an 18-year-old car? Having a mechanic you trust. One of my patients, who's a tow truck driver, gave me the mechanic's name. I suppose I could go on the internet and try to figure out how to fix a car, but if that site was designed for me to fix a car, it would tell me to not even think about it. Fortunately, MS is not like that. Now, there is a tremendous allure of taking oral therapy. It's a pill. I mean, almost all of us have a mother that told us to avoid sharp objects like shots and IVs. It's not confusing. But the main advantage of taking a pill is that it's a pill. The safety is extremely different from some of the injectables. The effectiveness, even among the different pills, is extremely different. Again, I've been on the pill for 2 years. I'm doing great. The pills are working great for me. It might be the pills are working great. It might be that you just aren't having a flare-up, even if you weren't on therapy. I had a relapse. I switched to that drug. I had a relapse. If you have a relapse on a medication, does that mean it's not working? It just means, gosh, Stu, we haven't found the cure yet. We want to pick a therapy that you can stay with, however. C. Everett Koop, the person who was the Surgeon General of the United States, some of you remember that guy? He had even less hair than me. I know that makes us memorable, right? He said, the very best drugs don't work in the medicine cabinets. You've got to actually take it. So for some people, it's like, I did injectables, and it's just not working anymore for me. I just can't do it. Or, I got to work. I can't go into an infusion center every month for an IV. It doesn't work for me. It's too expensive. Or maybe the doctor who was giving you that infusion, they're no longer in your insurance plan. Now you've got to figure out what you're going to do. Or your insurance has totally changed. Maybe you switch to Medicare. Maybe Medicare giving difficulty paying for one of those therapies. We want to pick a therapy so we can build your therapy around you. You're the center of the circle. Don't go to the doctor to make them happy. We're supposed to make you happy. When people are in trials at our center, I have like 4 rules of research. Rule number 1 is this: it's all about you. Don't forget that. One woman said to me, I've been waiting all my life for a man to say that. But really, it's about you. If you feel like it's about them when you go there, reassess. Where are you? Now, Gilenya, the first of the oral therapies, had a very strong effect. There are 3 large phase 3 trials. In the head-to-head trial against placebo, it decreased relapses 54% more than placebo. In the head-to-head trial against Adherence, a widely used therapy in MS, it decreased relapses 52% more than Adherence. And if you think 52 and 54% are really different, I have a bridge to talk to you about. It's for sale later. Now, how does this drug work? If I took a tube of your blood, if you have MS, and a tube of my blood, and then someone switched them around, I could tell whose was whose. If you have MS, you likely have some myelin-reactive T and B cells, lymphocytes. I have some that react abnormally against penicillin. I have a penicillin allergy. I have a very surefire method that's worked so far in my life to not worry about having a penicillin allergy. Can you figure out what that is? Don't take penicillin, exactly. Can you not have nerve cells? You've tried that, it doesn't work. What this does is it makes more of the lymphocytes simply store in the lymph nodes. At any given time, more than 98% of these lymphocytes are already in your lymph nodes. It just puts more of them in there so they can stay away from the brain and spinal cord where they can cause mischief. It doesn't suppress your immune system like Novantrin, certain chemotherapy medications might, Cytoxan might, Rituxan can. It just stores them away. But most of the action, what these cells do, is in your lymph glands. So we've all had a sore throat. You can feel the swollen glands in your neck. Lymph nodes are like filters for your blood. It just catches viruses, bacteria, or cancer cells in there and just knocks them dead. But don't worry, it doesn't turn your lymph nodes into roach motels. The lymphocytes check in, but they don't check out. I was worried about that initially, but that's not what happens. The presently approved dose is 0.5 milligram once a day. We initially studied a dose many times higher than that. And in the development process, they slowly lowered the dose. The presently approved dose is 0.5 milligram once a day. And now, though, the FDA has a rule. They have to sell the lowest possibly effective dose. So now we have an ongoing trial that's enrolling individuals where some people get 0.5 milligram, the standard dose. Some people get 1/4 milligram, half the present dose, and half the people get Copaxone. And like all trials, the medicines, the visits, the testing, it's all provided free by our research foundation. There's another trial coming up called the Sunbeam trial. And that studies a drug from a company called Receptos. And that's like a second-generation drug like Gilenya. It doesn't bind to some of the receptors in the heart and the eye, we think. But they can't say it doesn't, but we didn't test, so people will all get special eye examinations and heart examinations in the study as well. But in the early studies, it was very effective as well. And it may be like Gilenya, but it may offer a safety advantage. That trial is also enrolling individuals now at our center. The Radiance trial was a trial which is ongoing in our study, which is of that same medication. Again, there's no placebo in these trials. The Sunbeam trial is head-to-head against Adherence, interferon beta-1a, intramuscular 30 once a week. The Assess trial is against Copaxone. Aubagio, terflutamide, as I mentioned, in each of the trials it slowed disability, had a good effect on MRI and relapses. And again, it's not new because it's really a reworked drug that's been used for many years for treating rheumatoid arthritis. Because rheumatoid arthritis, is rheumatoid less common than MS or more common? Much more common. Because the drug's been on the market since 1990s for treating rheumatoid, and rheumatoid is so much more common than MS, more humans have been exposed to this drug than any other 2 or 3 MS drugs added together. So there's, garboons, I don't get to use that word a lot, garboons of safety data on that medication. It comes in 2 doses, 7 and 14 milligrams once a day. In the United States, both are available. Outside the United States, it's mostly just the 14, because the 14 have the strong effect on disability, but both doses decrease relapses by about 31%. But again, maybe people say, well, 31%, how effective is that? Remember, we included people with progressive MS in the study where relapses are less common. I mean, the average person in the study had 19 cc's of lesion in the brain, 2 to 3 times more spots than the average recent clinical trial in other medications. Now, the other thing about this drug that's unique is we know how it works. Having been involved with many other medications, I always joke it's fun to be involved in those other drugs because we change how we think it works every year. Abasia, we know what it does. It specifically binds to a receptor in cell called DHODH, dihydroorate dehydrogenase. And it works by preventing bursting of abnormal lymphocytes. If you get we know about a fourth of flare-ups to be preceded by the flu. When you get the flu, not only do your lymphocytes, like turn on to fight off the flu, but unfortunately in a non-specific way. It prevents that abnormal bursting, because if you have abnormal bursting, an increasing number of cells react against myelin, and some of those get across the blood-brain barrier, it could cause a problem. Again, Tecfidera was approved more recently based upon the DEFINE and CONFIRM trial. And the DEFINE trial against placebo, with placebo or once a day or 3 times a day, the once a day didn't work any better than placebo, but did have an effect on MRI relapses and disability. That was good. And then in the CONFIRM trial, it was head-to-head against Copaxone twice a day or 3 times a day. Unfortunately, the twice a day worked. But again, many people dropped out of the trial, so some of us still have some difficulty really interpreting how to interpret, how the companies reported the data from the trial. One of the problems we've had with Tecfidera is now there are several cases of people getting PML, the brain infection, that we've seen several hundred of now with Tysabri. It was felt initially, it was only in people whose white blood cell count was low from the drug, because some people on Tecfidera, it makes their blood cell count low. Like outside the United States, people are supposed to monitor blood counts quarterly. In the United States, it's said once a year. So once the first case of PML was reported, the package insert changed to warn about PML and to recommend more frequent blood monitoring if you're on Tecfidera. But in this last week's copy of New England Journal of Medicine, the flagship, most prestigious medical journal, there was a patient reporter who was on Tecfidera who got PML, proven by autopsy. So we also know the person for sure had MS, because that's the only definitive test, of course. But the person died of PML and their blood count wasn't low. So again, it's one more case. They're starting to add up. It's again making people a little bit nervous about that medication. I mean, different drugs have different safety, and each person wants something different. But with 12 drugs in the market, I recommend a really simple thing. Don't pick one that has death. A woman came to see me and said, I know you do a lot of research. My disease is getting so bad. If you got a drug that'll kill me or cure me, I'm ready to take it. I said, we have several like that, but so far it only works on the kill you part. So don't do that. Like Tecfidera doesn't kill you, Tysabri doesn't kill you, but there is that risk. I said to a woman 2 days ago in the office, well, the risk is small. She said, this is true. The same week she got MS, her husband actually won the lottery. So it shows, I know these things happen in my family, she said. I'm not willing to take that risk. Again, Lemtrada is a drug given once a year. We've used that at our center for almost 11 years now. What's interesting about the development of this medication, it wasn't against a placebo. It was against Rebif. And the reason why it's a head-to-head study against Rebif was that 11 years ago, that was felt hands down to be probably the most effective therapy by a consensus of MS specialists around the world. In the phase 2 trial, that drug did better against Rebif than any drug on the market, including Tysabri, did against placebo. So it had a 2 treatment effect. Again, the average person, as they follow along, actually got better. I'll show you a slide about this in a second. The 2 phase 3 trials that brought the drug to market, CARE-MS-1, people who were treatment naive, not been on therapy before. CARE-MS-2, people who had been on previous therapies, some who had been on several therapies, including some people who had failed Tysabri. Again, in phase 2, the relapse rate was the equivalent of a relapse every 20th year. So it's not like the trial went on for 20 years, but that's how low it was. With several dozen people who've been on that medication now decided for many years, I can tell you that I can count on one hand how many relapses over 10 years these couple dozen people have had. So it's really remarkable. It's not a cure, but it kind of gets close. If you want to look up a little video on the internet about that, one of our patients from Wisconsin, he was actually asked to speak at the FDA hearing. And he works in a paper mill, and he had gotten let go before when the economy went bad years ago. He finally got hired back on as a contractor. And they can't pay your way to speak at the FDA hearing because it's considered an inducement. Even the FDA wouldn't help him. But he and his wife were willing to try to get their not-so-good car all the way to the FDA hearing on the East Coast. And he asked his work for the day off without pay. They said, if you don't come to work, you're fired. Isn't that like love and kindness? What do you think? So actually, a reporter from Appleton, Wisconsin, came to his home and interviewed him, and they put it in the paper in Appleton, and they actually videoed his interview. If you just Google Appleton, Wisconsin, and Lemtrada, you can see his video, and just decide for yourself. I had no idea this was going on. I promise you. The drug company didn't know what was going on. You can see this guy sitting in the chair in a trailer in his house, talking about how he thought it worked for him. Now, there's a side effect of the drug that we have to watch for. We watch for people developing autoimmune disease. And the one that was seen commonly was thyroid disease. People's thyroid was normal. About a third of people's thyroid became slightly overactive. Ironically, several people liked having overactive thyroid. I mean, a couple of young women at our site, they liked having overactive thyroid because they lost weight. They had more energy. And one side effect of thyroid disease that some people had was not their eyes poking out, but their eyelids come up like this. And they thought their spouse was more interested in them. Just that their eyes are open like this, as if they were aroused. So, Lemtrada may get your attention, but hopefully it's not that reason. So everyone gets a blood test once a month afterwards. We look for a possible change in platelets, a possible change in your urine, and a thyroid test every third month. And again, the cost of all these different laboratories is rolled into the cost of drugs. So once you get the drug, the labs are all prepaid. You just get a thing for take it to Quest or LabCorp, or we'll even send someone to your house to draw your blood for you or to work whatever works easier for you. Like our gentleman we took care of in Wisconsin, he just had a service came to his house and they just drew his blood there. I'm not like the big watcher of Fox TV, but we gave the first dose of Lemtrada after it got FDA approved in the northern half of the United States. And so our center was shown on Fox TV with our first patient getting drugged about 2 months ago. Again, this is how people did. This is between the first 2 years and the second, and it's like worse, better, same. So 24% of people were a little worse after being on the drug for 2 years. 30% were a little bit worse on their disability score then. But then 76% of people were the same or better. At 3 years, 70% were same or better. Again, without getting more medication. So those yellow bars, those are people whose disease, whose level of disability improved. These are people whose exam their disability didn't slow down getting worse. It actually, disability did last. They were better, they were stronger, they could feel more, they could do certain things. When I've asked people who are in the trial, I just sit on this side of the desk. What should I tell people about Lemtrada? They tell me, it's like I don't have MS. And I said, what does that mean? It's like, anyone else in the room, like in the middle of the afternoon, your fatigue kind of hits? Or in the morning, maybe in the wintertime, you had more stiffness? These fluctuations for many patients sort of went away. And for a lot of people, they would sort of forget they have it. Because then you can go long periods of time without taking medication. The drug is out of the body very rapidly. It doesn't hang around. So there were several women who are still in the trial who had children and who are perfectly fine. One woman, 2 years after her second dose, asked me if she and her husband could have another baby. I said, it's fine, but you better ask your husband first. It's just the effect of this drug is sustained in the same way that if you had a stem cell transplant, we don't do one every year or once a month or something like that. It has reboots the immune system. And this data, and it was even more pronounced at the 5th year, again, less than 20% of people had a third dose. There's a woman who just moved up here from San Antonio, Texas, who's under our care now. Her last dose of this medication was 10 years ago. Now, you could go a couple of years without a flare. You might get better even without a medication, having ever been on a medication. 10 years would be kind of pushing it. So there are many ongoing trials. Some of you I want to thank for being part of that with us and other doctors and making these things come true. I don't hate MS more than you. For some of you, though, I've hated it longer. Some of you have hated it even longer than me. But I've hated this a long time. I've been involved in MS research for over 30 years. And so sometimes I just get sick of it. I say, okay, I'll just stay home in the garage. I'll cure MS, like Steve Jobs made the computer. It doesn't work that way. You hate MS. You might want to tinker around at home in the, in the den and cure MS. But by yourself, do you think that's possible? If you can, please say yes, though. But the way we'll cure this is by working together as community. So if you'd like to be involved in trial, please let us know. I can't do this alone. So I mentioned we have trials for relapsing MS, but we also have an ongoing trial in people with primary progressive MS. What's the name of the drug that's FDA approved for treating primary progressive MS? Exactly, silence, because there isn't one. This drug's in trial for primary progressive MS, and because it stimulates myelin growth in the earlier trial, there's a lot of reason to suggest even people with a lot of without a lot of inflammatory activity going on, this drug may be highly effective. There's another trial going on with ibutylast that's sponsored by National Institute of Health. The Northwestern is a center in Chicago that's a site for the previous trial of ibutylast, unfortunately, was not effective. We have the B-cell therapies, as I mentioned earlier, ocrelizumab, the OPERA trial, and ofatumumab just finished its phase 2 trial. Ocrelizumab has to be given IV, but ofatumumab, which is actually already approved for something else, is just given as a shot under the skin once a month. In the previous trial, we dosed some people even less frequently than that with outstanding results. Now, wouldn't it be nice if we had a good drug for treating secondary progressive MS? What if we had a vaccine for MS? Not a vaccine so you wouldn't get MS, because it's too late for that, right? You already have it. What if we could give you like a vaccine that would make you not have MS? So one study we have going on right now is a T-cell vaccine. One of the things I mentioned earlier, if you have MS, you likely have myelin-reactive T and B cells, lymphocytes in your body. What we do is we take a sample of blood and look to see if you have myelin-reactive T cells. Then we take a large amount of blood, and in like a unit of blood, like you'd give it Life Source, blood donation center, there may be like a half a drop of those cells, less. But we find those in the lab and we clone them. And then we treat them so they can't keep dividing, and we give them back as a shot. When we give them back to you as a shot in the arm, your body recognizes as foreign, because we treated them so they can't divide, and it kills them quickly. But because of the clones of the bad ones in you, your immune system is turned against your disease. Your immune system starts killing your myelin-reactive T cells. In the trial in relapse or remitting MS, the more we could drive down people's myelin-reactive T cell counts, the more disease just completely stopped in its tracks. Now we're doing this study in secondary progressive MS also. BAF312 is a drug from Novartis, again, a more selective drug like Gilenya from the people who make Gilenya. It's in trial for secondary progressive as well. There's a trial of Gilenya in primary progressive MS that I read out earlier, but unfortunately that study did not work. Some of the small molecule drugs like Gilenya actually can get into the brain. Now, there's another illness that looks like MS. And most of the people that I see with this disease were originally diagnosed with MS. But the story was something like this. I need to come to see you as an MS specialist, MS center, because I've tried a couple of these drugs and they haven't worked. I keep on getting optic neuritis, or my legs keep on getting worse. And some of these people we've assessed, they don't actually have MS. They have this different disease called NMO, or NMOSD, neuromyelitis optica. Sorry, I'm a specialist. We have big words. I didn't pick the name. NMO looks like MS, but it's not MS. It's caused by an autoimmune attack against a water receptor on nerves. There's a blood test that's abnormal in almost 3/4 of people with that disease, aquaporin antibody. And there's no drug yet FDA approved for NMO, but we have 3 drugs in trial for that. The Shagai trial is a fully humanized antibody, so it's just a shot under the skin. One woman who had, this woman could not go a month or two before she was in the study without being on steroids basically continuously. She failed several of the MS therapies, and she came to see us, and the reason why she failed was she didn't have MS. The trial is a time to first event. It's not like you get placebo for a year or two, or you get the drug for a year or two. It's like if you get drug or placebo, but if you have an event, you're on drug for sure. I'm almost sure this woman who came from Michigan to see us, for example, must have initially been on placebo because she had a flare-up, into the study in less than 2 months. Now she's on, we know for sure, drug, and it's like months now she's had not required any extra treatment. She's on vacation right as we speak, and she called up our nurse and just said this was such a blessing for her. She was so afraid of going on vacation because every time her family would try to go on a little trip, she would have another flare-up. It was a problem. Anyone have a flare-up at a convenient moment? No, icky. So again, many of these trials are recruiting people to participate with us. Again, liquidomode, as I mentioned, it's not approved yet for MS. It's in trials. The first trial was the Allegro trial, which I alluded to earlier. The second trial was an add-on to Avenex. Again, it had a strong effect. The ongoing trial for that now is Concerto, which I don't have like a little thing on the side, and that's looking at an even higher dose. We're looking at a higher dose because the safety of the drug was extraordinary. There were a few people in the trial who had elevated liver enzymes. At our side, it turned out the only people who turned out to have even a slight increase in liver enzymes turned out to be a couple of people on placebo. We're now looking at the higher dose, and in the primary progressive trial, we're looking at the higher dose and the lower dose as well. Again, that's a pill people take once a day. Again, this looks at how well did the drug affect tissue damage. So when the waiter went around the room, they said, well, how many new lesions and MRI scan would you like to have? None. How much myelin would you like to have? You'd like to have more. Can I have a double dip of the myelin, please? And these are people, this is the white matter of the brain, which is the spots, places we normally look on MRI scan. As you can see, the people not on drug, it decreased. On drug, they actually improved. This area here was when we looked at with the spectroscopy of the brain, parts of the brain that actually look normal on conventional MRI scan. And those areas also we saw remyelination occurring. And gray matter, the difference is the biggest. There's a big drop. So what do gray matter lesions do? These are the ones that are most closely correlate with long-term disability, but also correlate closely with cognitive problems. But no matter where we look at the brain, we can see a big difference. Now, you're not your MRI scan. As many of you know, what's the only test that's 100% definitive for diagnosing MS? Autopsy. We don't want to do that, okay? But this drug was good at helping nerves, get better. So again, I really want to thank you. I hear the hook from the side, Cathy saying, stop yakking so much. Sorry, I'm from a big family. I was a middle child, so this is my chance. But really, I want to really emphasize how impressed I am and how pleased I am to be able to share the stage with each one of you and let you know that I am really here to be of service to you and really thank from my heart Stu for all the work he's done for all the years for assisting people living with this disease.
Thank you. Thank you, thank you. By the way, the doctor keeps telling you, Stu. Stu only started this. This is MS Views and News, and I just want everybody to know that, because anybody that's going to be watching this later on, they need to know that it's not all about me doing for all of you, but it's everybody that's working with me at our organization, and it builds daily. Not just the volunteers, not just those that are working for us, but every single day we hear from people from around the world that want to know what they can do to help us and how we can get our programs to their areas. All right, next up, Cathy Myers.
I'm going to stand right here because if I stand behind the podium, you won't be able to see me. So I'm the short half of the team. My name is Cathy Meyer. I'm an MS nurse. That's what I do. I'm a research nurse. So when Dr. Wynn talked to you about the research studies, that's some of what I do. I'm also participatory in our clinic, our MS clinic. So I see individuals living with MS who come to see Dr. Wynn even if they're not in a research study. And I'm really good on the phone. And so a lot of what I do on the phone is talk to individuals about issues that they're having with their MS. And a lot of what I talk about is managing symptoms of MS. So let's get started a little bit. Dr. Wynn talked to you about what happens in MS. We know that spots on the MRI or lesions in the brain can lead to a relapse, and relapses that don't go all the way away can lead to disability. So you can see that symptom management really starts by knowing what happens in MS. Up here on the slide, you see that symptoms, what your symptoms look like, their presentation depends on where's the spot on the MRI, where's the lesion in the brain. The frontal part of the brain is your executive section. So if you have some thinking problems, if you're a little disinhibited with your emotions, laughing, crying, quick to temper. My husband says sometimes I have all three of those, laughing, crying, quick to temper, all in the same evening while we're sitting together in the living room. You might have a little more of that if you have multiple sclerosis and if you have a lesion in the frontal part of the brain. You can see the picture of the brain and what symptoms you might have. I know you're losing me when I go behind the podium. And what lesions you might have depending on where the spot is on the MRI or the lesion in the brain. So we talk a lot about, in our office, in our MS clinic, in the world of MS, about managing the disease of MS. Dr. Wynn just talked to you for about an hour about all the progress we've made over the years in managing multiple sclerosis, the disease. We also have made tremendous progress over the years in managing the symptoms of MS, and we do both of those simultaneously. We manage the disease and we manage the symptoms that are problematic to you. Our specific goals of treatment are really the overall management of your multiple sclerosis and then eliminating or reducing the symptoms that you have and what they do to your quality of life. Anybody in here ever had fatigue? And so what does that do to your day? We're going to talk a little bit about the effect of fatigue on your day. That you better do things early in the morning because, you know, it's 2 o'clock. Don't tell me anything else. I am done thinking today. We really want to also avoid secondary complications. So if you have difficulty walking and you found a way that you can walk and not fall over because you also have some balance problems, and maybe down the road you develop a hip problem because you've adjusted your walking to accommodate balance issues that you might have, and now you have a secondary problem, a problem with your hip. So by managing your symptoms, we can hopefully improve the quality of your life and reduce secondary complications that can be seen. You can see this is a big circle here that we're dealing with. One thing can lead to another, can lead to another. So we're always rearranging the pieces of the puzzle depending on what's going on with you as you sit at your visit today. Not what was going on last year or not what was going on last winter because now it's summer or now it's spring. Everybody who came into the office yesterday said, it's 80. It's going to take me a little while to get to the exam room. So fatigue is here. because we have warmer weather. So you can see that we have lots of different symptoms that occur, and managing one can actually improve something else. We'll talk a little bit about that. And again, we're going to talk about fatigue. So fatigue is a very common symptom. It may appear very early in the disease of multiple sclerosis, and it can attack easily and without warning. So the warm weather's coming, and which symptom is worse in the warm weather? Fatigue. We're going to talk about the symptom that's worse in the cold weather too, spasticity. So we're out of spasticity and we're into fatigue right now. We have our seasons. Heat and humidity really can make your MS symptoms more prominent, whether that's that you have a fever or an infection or it's 80 degrees outside. Now, I know that you all went through the hall of the exhibits as you came in. So you saw that somebody had a mister that you could use to keep yourself a little bit cool. You could put a little water, spray a little water. Somebody else had a cool necktie that you could use. Those really work. And so we talk a lot about managing fatigue in the warm weather in our MS clinic. We know that fatigue can really make other symptoms seem worse. You can really have a slowing of your cognition if you have fatigue. We call this fatigue above the neck. So again, it's 2 o'clock. Don't tell me anything else. I'm done thinking today. Or fatigue below the neck. And what's that called? Motor fatigue. Anybody have trouble? You get the groceries, you get them in the car, you drive home, you pull in the garage, and you can't get those bags out of the car and up those 2 steps to get into the house, and the ice cream's going to melt again. Anybody have issues with motor fatigue? So fatigue above the neck and fatigue below the neck is what we can see and is what we can talk about. And we really know that we can manage fatigue. We know 75 to 95% of individuals living with MS have fatigue. It's a common symptom. It's an early symptom. It can be debilitating. We know that we want to, first of all, we want to make sure that your fatigue isn't coming from something else. So what's a common symptom of being hypothyroid? Fatigue. So we want to check out your thyroid gland. We want to do a blood test. What are other things that can make you fatigued? How about anemia? So we really want to get a complete blood count. How about if you have a sleep disorder? If you don't sleep, you're going to be fatigued. So we really want to look at you and your general health as we evaluate what's causing your fatigue. We know that we can manage MS, so we checked you all out. You got a good physical exam, and now we have to look at how we're going to manage this MS fatigue. So what's a lifestyle change? A lifestyle change, and I will give you an example. My mom used to live next door to an elderly gentleman. He was about 88 years old, and he'd always be standing on the porch. I'd be pulling up in the morning. And I'd say, "How are you?" And he'd say, "I'm fine." One day I said, "How are you?" He says, "You know, if I would have known I was going to live this long, I would have taken better care of myself." That's a lesson. Out of the mouths of babes or out of the mouths of someone who was 88 years old standing on the porch. Lifestyle change means get out of the recliner, get off the couch, take care of yourself. Regular exercise is really important. So what's the best exercise if you have multiple sclerosis? Well, if you talk to these guys right here, they might say getting in the water. If you talk to somebody sitting over here, they might say, "I ride the bike." Somebody else might say, "I do yoga." Pick what works for you and start. Start tomorrow. Start today. Start today by thinking about what works for you and how can you get started. That's a lifestyle change. Effectively use your energy. If you know that at 2 o'clock you're done thinking, do the important thinking stuff in the morning. Think about the dinner. Think about managing the kids' homework. Do the important thinking stuff in the morning. That's how you can effectively expend your energy. We also know that we have medications to manage fatigue. Fatigue above the neck, we might use Provigil, Nuvigil, we might use one of the stimulant medications. Fatigue below the neck, we have an exhibitor who was here with us today for Ampera, and Ampera is used for motor fatigue. Can we use these medicines at the same time? Fatigue above the neck and fatigue below the neck? We sure can. And how do you know what's the best choice for you? You talk to your MS doctor and you talk to your MS nurse and you tell them what's going on. What's going on with you today and how can we look at managing this? So our society is full of people who don't sleep. We're sleep deprived. What happens when you're sleep deprived? You get cranky. When you're sleep deprived.
Don't look at me when you say that.
Sometimes we joke in our office because we start early and we usually finish late in the day. And so sometimes at the very end of the day I'll say, which is late, I'll say, I think I should go home now. I'm getting cranky. And it's because we really need to manage not only our waking activities, but we need to manage our nighttime activities. We know that as many as 70 million people in the United States can have sleep issues, 20% of the general population, and this is even higher if you have multiple sclerosis, 25 to 54%. We know that this can be caused by sleep apnea. So all you wives out there, does your husband snore? All you husbands, does your wife snore? So one of the signs of sleep apnea might be snoring, and it could be a good idea to get that checked out. How about insomnia? Can't fall asleep? Or you fall asleep, 2 o'clock I'm up, I'm watching CNN. There we go. So if you have a sleep apnea issue, or you have an insomnia problem, or something particular with multiple sclerosis might be restless legs. So again, here we go. Husbands, ask your wives, do my legs move at night? Do I kick you, honey? Did I mean to kick you, or was I kicking you in my sleep? So ask your partner if any of these things are occurring during the night. We know that fatigue in MS is reported in 70 to 90% of individuals, which may be worse with sleep-related issues. And we also know that we have good specialists available to evaluate sleep. We now have a home version of a sleep study. So a lot of individuals don't have to go to the sleep lab anymore. You take the little suitcase home, and you can do your sleep test at home, and you can come back and it will be read by the sleep specialist, and they can talk to you about the findings, and they can work with you to manage any sleep issues that you might have. We know we have treatments for sleep issues. We know we have CPAP machines, we have medications for insomnia. We can talk to you about the different medications for falling asleep, staying asleep. We also know we have good medications available to treat restless leg syndrome. But first of all, you have to talk to us. If there's a problem, you have to put it on your list, which you're making before you come to the visit. Or at least you're trying to make it in the waiting room. Or you're making it in the exam room on a piece of scrap paper before the doctor and the nurse come in. So if you have a sleep issue, talk about it. Because we know if you have MS and if you don't sleep, and if there are a number of other things going on in your life that maybe aren't the best they could be, that maybe you might have some signs or symptoms of depression. Could be episodic, could come and go. We know that depression occurs in 3 to 5% of the general population, but it could be as high as 60% in individuals living with MS. And why might that be? Well, just getting the diagnosis of a chronic progressive neurologic illness when you're 25 is very depressing, could be very depressing. It's a stunner. Also, remember the executive part of the brain? If you have a spot there on your MRI, a lesion in the brain, it can be a cause of depression. And just the day-to-day difficulties that you might face in the real world and as an individual living with multiple sclerosis could create some signs and symptoms of depression. It's okay to talk to your doctor about that and your nurse. It's okay to brainstorm, make strategies. It's okay to talk to your doctor and your nurse about that. Some of the characteristics of depression are listed on this slide. And I think we all recognize that there are many different characteristics of depression. We also know that we can diagnose depression and we have appropriate treatments available. Symptoms can be confused with other symptoms of multiple sclerosis, and I immediately think of pseudobulbar affect. I have had many individuals who've come to our office who've been sitting with me for a research visit before Dr. Wynn came in and who started to cry. And pseudobulbar affect is inappropriate laughing or crying. Again, crying when there's puppies on the TV screen, laughing when it's not appropriate to laugh, or quick to temper. So we really have to look at what's going on. Is it pseudobulbar affect, which is treated totally different than multiple sclerosis depression? You don't have to know the answer to that. Just like Dr. Wynn doesn't have to fix his car, thank goodness. You don't have to know the answer to what is this. You have to write down what's going on with you, and then you have to talk to your MS doctor and your MS nurse. Because we do have good medications. We also have good talking therapies. And we also can use exercise as one of the therapies for multiple sclerosis. So you know what I think one of the best things about MS support groups is? You have somebody to talk to who's living with multiple sclerosis. And so being part of an MS support group is so valuable. I have to tell you, I always appreciate it when an MS support group asks me to come and maybe talk a little bit, because I learn as much from you as maybe you'll learn from me. You have figured out so many things. So invite us to come and talk to you, because we will learn from you, just like hopefully you can learn something from us. Cognitive impairment is common in 45 to 60% of individuals living with multiple sclerosis. So what does that look like? Well, the two areas that are the most commonly seen are procedures with multiple steps and next day recall. So remember when your MS nurse taught you how to use that first injectable therapy? Had multiple steps in that. And you had to remember it the next day because you had to do it again. So what we learned as MS nurses was, have you bring someone else along with you, a second set of ears. Write it down. Make it simple so that we could accommodate procedures with multiple steps and remembering the next day. These are strategies that you can use in your daily life to maybe overcome some of the problems that could occur with cognitive impairment. You might have some short-term memory loss, some impaired judgment, some difficulties with learning or word finding, or executive functioning. So speaking as an MS nurse, I don't have MS, but speaking also as an MS nurse who's no longer 30 or 40 or 50, I can tell you that my solution for short-term memory problems is that I have a spouse who I can look to and say, what was his wife's name again? Did we meet these people before, honey? So make a strategy with your team with your healthcare professionals. And you too can have success with some of these signs of cognitive impairment. Trouble remembering, difficulty finding words, difficulty following directions. Procedures with multiple steps fits in right there. Sometimes you might have some trouble remembering emotional, you might have some emotional changes. You might be forgetting a thought or a sentence. Write it down. We had a neurologist who worked with us years ago, and maybe he'll look at MS News and Views and see this. His name was Dr. Dennis O'Brien. The first time I met him, he had one of those little 10-cent notebooks in his pocket and a pen. I don't know how many notebooks he had to buy, because every time I told him something, he'd say, wait. He'd whip out that notebook and he'd write it down. And you know, for Dr. O'Brien, he lived in multiple worlds. He practiced at the hospital, he practiced at the office, he practiced in the MS clinic, and so his solution was to write it down. And that's how I learned many years ago to write things down. And that's a good strategy. If you have some memory issues, write things down. I don't think the notebooks cost a dime anymore, though. I think they cost, and there's probably not any Woolworths anymore, is there? No. So, write it down. You can survive the cognitive dysfunction that you may have in multiple sclerosis. These are maybe some more serious problems that you might see as a result of cognitive dysfunction. Poor reviews at work. If you're going to have your job evaluation, don't have it at 4 o'clock. Do it first thing in the morning when you're fresh. It might take you more time to accomplish something. You might have some problems with the checkbook. If you have problems with the checkbook, don't hide it from your spouse. Let them do the checkbook. Don't stop balancing the checkbook. You will be in big trouble. Speaking of one who stopped balancing the checkbook, turn it over to the person who maybe is more talented at that. You might have problems following a recipe. You might have problems remembering where you put something. You might have problems answering the phone on the remote control from the TV. You might not be able to find the telephone because you were getting dinner ready when your daughter called and you put the phone in the fridge when you got done talking to her. Or you might be like that lady on TV. Have you seen my glasses? So some of these things may occur. Those aren't as serious as the last one on here, which is car accidents. So if you have trouble remembering where you're supposed to go, or if you have trouble functioning while you're driving the car, this is a time to make friends with a driver and be realistic about what you can do. We know we have testing available to determine what areas you might be having trouble in, neuropsychiatric testing. We know that we can teach you lots of techniques to manage the areas that are difficult for you. We also know that taking your disease-modifying therapies is important because this is how we minimize lesions on the brain. And where do symptoms come from? Lesions on the brain. We have pharmacologic agents available for cognitive dysfunction also, and your MS doctor and your MS nurse can really talk to you about that. Spasticity is another symptom that we see most prominently maybe in the winter time. Spasticity was once described to me as, my legs are like boards. It's difficult to get into the car because my legs don't bend. And so spasticity can really have an influence on what you do every day of your life. It just can make things a little bit more difficult. It can be described as tightness, pulling, tugging, aching. My legs hurt because they're so tight. Or my arms hurt because they're so tight. So this is really a symptom that we can manage with MS. We know that spasticity can be worse not only in the wintertime, but if you have an infection, if you have any kind of inflammation. What's a common type of infection that you might have with multiple sclerosis? A urinary tract infection. And sometimes the first indication you have is my legs are stiff. I woke up this morning, the legs are like boards. My first question always is, what are you brewing? So infection or inflammation, which can raise your body temperature, can make your MS symptoms more prominent, and there we go, your spasticity is worse. We can manage spasticity with medications. We have some very safe medications that we've used for years. We also can manage spasticity with exercise, with stretching, with positioning, with getting a seating expert to work with you. If you're using a wheelchair most of the time, get a proper cushion. Get a seating expert, that's exactly what they're called, to work with you and get proper positioning in the wheelchair so that you don't develop worsened spasticity. We do have surgical interventions. Many individuals find an intrathecal baclofen pump to be effective in managing their spasticity. A minuscule amount of baclofen is delivered intrathecally, so in the back, and the baclofen can get the most effect for the smallest medication. So you know how you've seen people with a pacemaker and you can see the little round circle off? That's a common thing. A baclofen pump is like a little round circle, but it's at a different place. It's implanted in the abdomen. The catheter is tunneled around to the back, to the intrathecal space. The medication, the pump is filled every 6 months, and the medication is delivered right to the intrathecal space, so you get maximum effect with a minuscule dose. You don't get the drowsiness that might be seen with some of the oral medications. So we have good medications for spasticity, and if this is a concern, talk to your MS doctor and your MS nurse. So one of the common symptoms that I hear about is problems with the bladder. Gotta go, gotta go, gotta go, or can't go. So failure to store the urine could be gotta go, gotta go, gotta go. And then again, we could have failure to empty the bladder, which is can also be a difficulty that we see. So we want to diagnose what's going on. We can do a bladder scan. We can have you see the urologist. And then we want to decide, do we need to have a medication to talk to you about? Do we want to teach you techniques for emptying the bladder on a regular basis? Do we need to maybe use a catheter so that we can prevent urinary tract infections? But you know, one of the managements of having a healthy bladder, it kind of seems like these two things don't go together, is drinking lots of water. So if you had that gotta go, gotta go, gotta go, and your nurse said, I want you to drink 6 to 8 glasses of water a day, you would think to yourself, that's not happening. No, I'm not making that. But you want to promote bladder health by being well hydrated. We also tend to recommend vitamin C, 500 milligrams in the morning, 500 milligrams in the afternoon. Vitamin C is ascorbic acid. What it does is it helps to neutralize the bacteria that's in the urine so it doesn't become a problem for you. So simple vitamin C, 500 milligrams in the morning, 500 milligrams in the afternoon, can really promote bladder health. And it is important to drink 6 to 8 glasses of water a day. You might have to juggle around when you're drinking those. I wouldn't drink 6 glasses of water and then get on the train for an hour commute home. That would not be working. But think about being adequately hydrated and take steps to try to make that happen as you manage your bladder. And so 1.5 to 2 quarts of fluid a day. You know, you don't want to be drinking all this coffee and all these diet drinks because we know caffeine and Nutraceut are really bladder irritants. So if you have to have your cup of coffee, have one in the morning and then have decaf and have water. If you have to have diet soda, have one in the middle of the day, but make sure you're getting your water in between. If you're having an issue with gotta go, gotta go, gotta go with your bladder, make sure you have quick access to the bathroom. Make sure you get up from your table and leave to go to the bathroom before you have to go. And you can do a lot about managing your bladder just by maybe altering how you do things in your day. So the other problem is that individuals living with MS may have some issues with neurogenic bowel. Most commonly, we see constipation. Occasionally, we see diarrhea or loose stools. Constipation really can be easily managed through diet. So there's a difference between roughage and fiber. All of our primary care doctors told us years ago, you got to start taking that fiber. You got to promote a healthy colon. My husband got that jar of fiber. He got that giant jar of fiber, put it in the kitchen. So this is what you need to know. If you have issues with constipation, roughage is raw fruits and vegetables. Fiber is cooked fruits and vegetables or those fiber supplements. Raw fruits and vegetables will help you be regular. Cooked fruits and vegetables or a lot of fiber can sometimes be like putting sticks in the cement mixer. So if you put sticks in the cement mixer, does the cement come out easier? No. Be adequately hydrated, eat lots of roughage, and this is one way to manage constipation and to prevent it. It's also okay to use a regular stool softener every day. Laxatives on a regular basis are really not recommended, but a regular stool softener every day helps the bowel retain water so the stool can pass out easier. And this is one way to really avoid constipation or keep it to a minimum, is to do these dietary tricks, be well hydrated, and use a stool softener if you need to. So what if you have the opposite problem? What if you have some difficulty with loose stools? Get that fiber, cooked fruits and vegetables. You can use that fiber, breads, bagels. So years ago, my pediatrician recommended something when I had a child who was a baby, who was having an issue with some loose stools in the diaper. He said, use the brat diet. The brat diet has served me well as an MS nurse. Bananas, rice, applesauce, and tea. Safe to use for the children or the grandchildren. Also safe to use for the adults. And this is one way that maybe you can control this problem of having loose stools. So we talk about tremor a lot of times, and this is one of our most difficult symptoms to control. Tremor really can have an impact on everything you do every day. Your walking, your eating, your ability to write. We know that tremor really can affect the head, the limbs, the trunk, the eye movements, and the speech. So everything. We also know that tremor is difficult to treat, but not impossible. If this is an issue that really is having an impact on the quality of your life, you should write it on your list, but I will tell you that your doctor will notice if you're having some issues with tremor, and this is something we can work on. We can manage tremor with medications. We can manage tremor with other strategies that are not medications. And we also have a surgical technique we can use called deep brain stimulation. We're getting to the end of our symptoms here, and actually, I don't want to say I've saved the best for last, because this is really a symptom that is bothersome. Pain. Pain can look differently in individuals. Pain can look differently in the same individual. Pain can be that staccato pain in the face, trigeminal neuralgia. Pain can be burning in the feet, in the hands. Pain can have many different descriptions. And so this is something you should definitely talk to your MS doctor and your MS nurse about. It can be neuropathic along the nerves. It can be musculoskeletal in the joints. Pain can be in the eye. Anybody ever had optic neuritis? Often, that's a first symptom. That gets your attention, doesn't it? Pain with eye movement, man, that gets you on the phone, and you're calling your doctor's office, and you're telling us about it, and we're bringing you in right away because we want to talk to you and see what's going on. Spasticity can be painful. My legs are like boards. That's painful. And dystonia, difficulty with muscle tone, can be painful also. So whatever your pain looks like, you should talk to your doctor about it. You should talk to your MS nurse about it. And we can help you develop strategies. We can also, some of the strategies are here on this slide. We can also talk to you about medications that you might use. Physical therapy really is a good strategy for many different symptoms of MS. And I highly recommend asking for an order for physical therapy from your MS doctor. Physical therapy, evaluate and treat. What that means is see the physical therapist and let them see what symptoms are problematic to you and what problems you have moving around, and then let them make a plan that's right for you. Again, we have medication options. We know we can use some of the medications used for epilepsy can be used for pain in multiple sclerosis. We know that the anti-spasticity medicines can be used for pain in multiple sclerosis. We also know that you can be referred to a pain clinic if this is something that really is more difficult to treat. And remember that pump we can use for baclofen that's implanted under the skin? There are individuals who have serious problems with pain who can have medication in the pump to manage pain also. So, we've talked about a lot of symptoms today. You're not going to get all of them. You're probably not even going to get many of them. But whatever symptom you get, it can be problematic. And you should never hesitate to bring this up with your MS doctor and your MS nurse. So what if you're doing pretty well? Your visits with your doctor are 6 months apart, and the last time you saw your doctor it was September, and now it's maybe December, and it's cold out, and my legs are like boards. They were good when I was with you in September, doctor. What do you do about that? Call us. Call your MS doctor. Call your MS nurse. Brainstorm on the telephone, or maybe have an extra visit with your MS team, because this is what your team is there for. The important thing is to make a plan and build a team. Your plan is simply a function of what your goals are. Your team are those that support you. Your family, your community, your MS support groups, and your healthcare team, your MS doctor, your MS nurse, your primary care doctor. You might have a urologist. You might have a psychologist. So your healthcare team is important also. But remember when Dr. Wynn told you the first rule of research? Who remembers it? Yeah, right. It's all about you. So it's also all about you. Even if you're not in a clinical research study, it's all about you. Make a plan, build a team, invite us to be part of your team, and let us know what's going on with you so we can brainstorm ways to not only manage your MS, but to manage the symptoms of MS. And thank you very much. This is a difficult task after lunch. Thank you very much.
Thank you, Cathy. Thank you, thank you. Now, firstly, for all those that came in late, just remember that you will be able to watch what happened before you arrived, because this will be probably up on our YouTube channel. And for those that don't know, it's called the MS Views and News Learning Channel. Well, that will be on our YouTube channel probably within a week, and you'll be able to see everything that you missed today. And for those who just don't remember, well, you'll be able to do that too, okay? So, by the way, did anybody see or not see that we have MS ID cards outside? I know some of the other organizations have it, but you know, we have it too. So if you didn't get one, you can get one on your way out. The video archives we just spoke about. Listen, some people came to me during their intermissions outside and asking me if we've ever done certain types of programs, whether it be on intimacy, caregiver related, or otherwise. And the answer is yes, we have done this. So you can go to that YouTube learning channel of ours, and you can find the titles that have impact of MS on the family. And on there, we've either had a urologist talking, or we've had social workers, we've had psychologists, we've had neuropsychologists, we've had nurse practitioners relating to a lot of these different things that can greatly affect what's going on inside your household. When to tell the kids, when to tell your parents, when to tell others around you, what to do with work, okay? We have impact not just on the family, but impact on your work environment. So again, go to the channel. You want to know how to find it, you go to the website. On the top of the website, which you cannot see from here right now, there are drop-down boxes. And one of them is to click on to go to the YouTube channel. Or you just go to youtube.com/MSViewsAndNews. And if you can't remember any of all this, just send us an email and we'll tell you where to go, okay? So now what's going to happen is you guys are going to get ready and ask questions. And what's going to happen here too, I need to lose 5 pounds. And I need to run around this room and get everybody's questions, okay? So I expect that when you all leave here later on, I'm going to be very hungry because I'm going to have to regain what I lost, okay? So lots of questions. I'm going to start off on that side of the room. If anybody on that side of the room has questions, I'll be there in a little while, all right? But let's start with a show of hands of who needs me to go over to you. Thank you.
Free lunch, whoever asked the first question.
Okay, sorry. Oh, can't go with the box. Okay. I have a pain pump implant at this point. It is morphine, and which I started having a bad reaction to it. So they cut it down, and they're going to be filling it with baclofen. Now, is the baclofen going to help with my leg pain or the spasms or both, or I mean, I know you can't say everything, but can I look forward to it working the same as the morphine did?
So the question is, I have an implanted pump for pain. I've had morphine and I had a reaction to it. My doctor's going to switch baclofen into the pump. So I can give a general answer for how these pumps work and the medication work, without examining you, giving you the answer like be turning into WebMD. WebMD is the perfect person to go to if you don't have a doctor who will talk to you. If the pain is pain from cramping and spasticity or burning, baclofen will also work. Often we'll mix very minuscule amounts of morphine or some of the other narcotics, hydromorphone dilaudid, fentanyl, others in the pump as well. Sometimes we'll use small amounts of local anesthetic medications, bupivacaine, like Novocaine, in the pump as well. Often use a combination. It's often very effective. Just to, again, because I know most people in the room probably aren't familiar with the pumps. As Cathy mentioned, a minuscule amount. The baclofen pills come in 10 and 20. It takes a 500th amount of baclofen when you put it in the pump. A 20 milligram is, again, the small, like one of the pill sizes. The whole pump holds 20 milligrams. That lasts 6 months. That's how little it takes. Again, morphine is 200 times more effective. That's why taking these medications works. Narcotics in general don't work for MS pain. They just make people drowsy and constipated. In the pump, you give a 200th amount of dose, which is why it tends to make people not drowsy. At one point, we were using more pumps than the Cleveland Clinic at our center. So many people have a nice response to baclofen for the pain. Many people who have pain that even that neuropathic, like burning, squeezing, burning, like the dog is chewing on my leg pain, there's tarantulas crawling on my leg pain, will often, who I think, or they have a lot of superimposed bad hip or arthritis pain, where I'm thinking I may use a narcotic, will often try baclofen first, because it's minuscule side effects, it's very inexpensive as well. And again, it's very easy to manage this. In terms of spasticity, again, as Cathy mentioned, spasticity is worse often when you first wake up in the morning because you're coldest then. So the ideal time to take a pill of baclofen would be 2 hours before you wake up. Can you take a pill hours to her? No, you're not supposed. You want to be sleeping at night. The pump doesn't know if you're awake. We can have the pump automatically adjusting your dose, more than 10 times a day, including while you're asleep. Some people need a lot more while they're asleep. Some people need more while they're awake. It's just different from person to person and different on the season. So you may have excellent response. It's going to be different for different individuals. But again, you want someone who's familiar with MS. A lot of the people who do pumps are pain specialists. They're not MS specialists. So some of the pain specialists have us tell them what to do to the pump, but they're the ones who are actually managing the pump, or we're managing the pumps ourselves.
We're going to have a lot of questions going around the room, so I'm going to ask that we try to answer as best as quick, okay? And also, try to make it general questions, not necessarily only about you.
Are there only 3 stages of MS still?
Are there 3 stages of MS?
Yes.
We divided MS into relapse remitting, secondary progressive, and primary progressive. Some people have heard me joke, where do those terms come from? Were they handed down from Mount Sinai? They actually were. 25, 30 years ago, Mount Sinai Hospital in New York sent a questionnaire around to large MS centers like ours and asked how we describe them. Those are the terms that were used. But MS is MS. Primary progressive and the relapsing forms of MS are the only 2 forms that the FDA recognizes. The main reason for treating relapse remitting MS is so it does not become progressive. But there are certain people, including one person who was in the stage early who had bad progressive MS, who their MS starts to become goes away. There's no important thing to take away from today also is there's no symptom of MS that's necessarily not reversible. And again, in talking about pain, the worst pain of MS, actually Cathy didn't mention, the worst symptom of MS, I always say, is this one, a broken heart. So again, that's one we can avoid by treating MS.
Next question's back here.
Hi, Dr. Wynn. Just asking about that take-home sleep study. How does one go about finding out about that?
Good. So at our center, I was actually, when I first came back to Chicago years ago from the Mayo Clinic, I was the first doctor north of New Chicago who did sleep. The people who were there when I came back here, they're retired now. So I'm actually also the most senior person doing sleep in Chicago. Several years ago, we took a look at a couple of key facts. 82% of men in the general population with sleep apnea aren't diagnosed. Over 90% of women are not diagnosed. And there are lots of reasons why. One is if you make people do an inpatient study, which costs thousands of dollars, for disease that most people don't believe they have in the first place, particularly men. I don't snore. Yeah, the shingles just fell off the roof for no reason. They don't do it. So we worked at the technology to develop in-home studies. So we've been doing that for several years. I mean, there's some people who have to do it into the lab, but most people can just have them do it in their home. Beginning the 1st of next month, the 4 major insurance carriers are no longer going to pay for in-lab sleep studies, except under unusual circumstances. So now the at-home technology, which we've been using for several years, is becoming only when the major commercial insurance carriers are going to be paying for.
All right, this way.
Yeah, Dr. Wynn, one of the interesting things for me was the discussion on Lemtrada, where that seems to be the only dual-purpose medication on the market, and so that it stops lesions and but in addition to that, it improves EDSS scores, which the others just seem that the other medications seem that they only slow progression, where this one actually improves some of the disability. Did I understand that correctly?
Yes. Now, when we first did a phase 2 trial, I didn't know if the drug would work, and people in the very early proof of concept study had to be naive to treatment. The only people I put in the trial were people who had a kind of MS. I didn't think any of the drugs I had available at that time would be valuable. The first woman I put in this, in general, the more fair one's skin, the more likely you are to get MS. But the more likely you are for the disease in the first 10 years to be mild. The first woman we put in the study had 42 contrast-enhancing lesions, active lesions, and is part Puerto Rican, part African American, a pattern which some people have referred to as malignant MS. It's now been almost 11 years. She's had no relapses. Her neurologic examination has become almost normal. She's only had 3 doses of drug. And as I may have mentioned earlier, 2 years after her second dose of drug, she asked me if she could have another baby, and I said, it's okay with me, but you have to ask your husband first. She's done extraordinarily well on therapy. One woman who was in the study who did develop overactive thyroid told me, well, it's like I don't have MS. And I said, well, to play devil's advocate, you did get thyroid disease. She said, are you asking me if I would trade thyroid disease for my MS? That was an easy one. But again, it's something people want to have a talk to with their doctors about. And again, there will be more ongoing trials of the drug, I'm sure, which I'll learn about at the meeting beginning when I get to Washington, D.C. today.
Cathy, what is a rhizotomy? Dr. Wynn.
A rhizotomy is where actually they cut the nerves. So the symptomatic slides are a little old. Some of the things in there we don't do very often anymore. So the older set of slides include a lobotomy. We don't do that one anymore. That deck was from the lobotomy deck was from the 1950s. There still are some pain centers where they actually go in and cut nerves in people's back. Well, if your leg is weak, we'll just cut the nerves in your back, then you won't feel it. It doesn't actually work to cut nerves because if you have like burning pain in your feet, you localize the pain down there, but that's not where the problem's occurring. I walked in the office one time and a man is smacking himself in the thigh. I said, Mark, what are you doing? He goes, I'm having a flare-up, my leg isn't working. I said, don't hit your leg. Your leg is the innocent bystander here. It's the problem is higher up. You got like a short circuit higher up. Your leg is the innocent bystander. So people have massage from us, that's good. That decreases, spasticity, muscle tone and things like that. That's good. But the problem isn't in your leg. It's the nerves that go down to there that connect to that. And pain, the pain isn't from a thing in your leg. Like if you have arthritis of your knee hurts, and that's where the inflammation is. In MS, the inflammation isn't in the joint. It's, again, in the circuit breaker. If I try to turn on the light next to my bed, and I turned it on a couple of times, it didn't go on, then I changed the light bulb 3 times, it still didn't work. Then I noticed a lamp wasn't plugged in, then I changed the lamp 3 times, it still didn't work. Even I would figure out circuit breaker time. MS is a circuit breaker disease.
Next question.
Hi.
I had one for Cathy.
You gotta wait.
Oh, I'm sorry, I thought you were done.
In a Lemtrada, what happens if you have a reaction to it, and once it's put into your system?
So the body's out of the system relatively quickly. It's a monoclonal antibody like some of the other monoclonal antibodies we use for many different diseases. So the drug doesn't stay in the body. Its effect is sustained in the same way if someone had a stem cell transplant, you don't get it done repeatedly. But the drug doesn't stay in the body. The drug, one simplistic way of talking about it, just basically reboots the immune system. Someone with MS has cells in their body that react abnormally against myelin. We want to make those gone. Because once those are gone, the disease is gone. And then I always think about, what was the very first question I asked when I was still a graduate student studying viruses in basic science immunology many years ago? I asked the head of the MS Center where I was studying on the West Coast, how do you make people with MS better? The answer he gave me I didn't understand for more than 20 years, so I'll explain it. He said the way you make people with MS better is you stop them from getting worse. What he meant is this. Everybody with MS, unfortunately, is always getting worse. But the body has many repair processes, many of which we may not figure out the details of in our lifetime. The more we can stop the disease, the more these repair processes will take over. Like, for those of you who had a relapse, how come they ever got better? How come your lesions ever went away? Some lesions may have ever gone away. Lemtrada reboots the immune system, which dramatically slows down the progression of disease, which is why we have people now 10 years since their last dose.
Okay, thank you.
But the answer on every slide you'll ever see at a promotional program is the exact mechanism by which this work is unknown because we don't know exactly what causes MS yet.
Hi.
Hi.
I'm newly diagnosed, and I just had a couple questions. The first one is, I feel like I get symptoms that last like 2 days, and then they'll go away. The last 2 days and go away. Besides being in the hospital, which I don't want to do again, when do I call the doctor, and what do I do for that?
So that's a great question. When do I call the doctor? One of the first questions that everyone should have who has MS when you see your doctor is ask them that question. There's one doctor I know who runs this very large MS center on the East Coast. She sees people once a year, and sometimes her nurse practitioner sees a patient, and specifically tells people, seriously, don't call me if you have relapse. They're not worth treating. It doesn't make any difference. So I don't have MS, but if that was me, I wouldn't want that doctor. So you want to ask that doctor. Now, early in the disease, one of the following things happens. People start cutting their fingers and toes. When I was 2 years old, I was the world. Then I got a little older, then I heard a booming voice, probably my father screaming. Then I suddenly differentiated. As life went on, I became an adolescent. My body started to change. I started counting my fingers and toes. Then I noted girls as an adolescent boy, and I counted their fingers and toes. I stopped doing that. Then I got married, counted her fingers and toes, stopped that. And then had children, counted their fingers and toes. Then people get a chronic illness, they start counting their fingers and toes. Oh, my leg is numb again. Almost everybody with MS does not get diagnosed until they finally have an episode that doesn't go away. And most people, when they get diagnosed, go, you know, I think I've had this for years, because that thing in my vision in my eye, could that have been part of this? So form a close team with your doctor. When should I call you? Who do I contact in our office? At one time, there were only 2 full-time nurses dedicated to MS in Chicago. They both were at our MS center. Northwestern had 2, but they shared one spot, and they both retired last year. So make sure there's a point of contact. One of the rules of the National MS Society is a comprehensive care center like ours. You have to have a 24-hour, 7-day-a-week contact person, and Cathy is that specialist. And 2 of us take calls all the time.
Next question.
So is the Lemtrada approved, or is it still in trial?
Lemtrada was approved last year in the United States. It was approved in many other countries about a year and a half before that. And again, we've been using it about 11 years at our center, and as well as other centers around the United States and across the world. We were one of 2 Chicago sites that was involved in the trials. We were in pretty much all of the trials.
The other question I had was, is there anything to do about that Lermit sign besides not moving your neck?
Is there anything to treat with Lermit signs? Absolutely. So Lermit is one kind of pain. Again, as I mentioned, MS is a disease, a circuit breaker, like little short circuits. Ooh, tingling, little sparks coming out my rear end. So the other disease where nerves are firing off when they're not supposed to are the drugs used for epilepsy. I tend to use a lot of oxcarbazepine, trilopitol, or carbamazepine, Tegretol. Many people like to use gabapentin, Neurontin. So the drugs used for nerve pain, like Lermits, are the ones that are also sometimes used for epilepsy.
Use all those difficult terms. How are they supposed to remember that?
A man came into the office with his wife and said, and I'm sure many of you will understand this. He said, I know you don't think we can listen as fast as you talk, but I can tell you're thinking like a chess player 2 moves ahead. I'm sure most of you would agree with me. In MS, we can't afford to be checker players. The purpose of having a support group, people you talk to, the value of having MS, views and news and other resources is so you can know what to do with what happens. You don't have to live in the fear of the disease. You can live with MS, but live the same life you were going to live before with a few workarounds, but not give up on any of your dreams, any.
Before I hit the next question, please just show me your hands of who wants to talk so I know where I'm going to next. Thank you. Got it.
Yes, I'd like to know what your thoughts are of I've been reading a lot about the paleo-type diets for helping MS.
So what about diet for MS? One's, I don't know about you, but I got filled full of religious aphorisms as a child. One is like, life is like that 3-legged stool. One is having a healthy diet. Don't just eat food that comes out of a bag with a Happy Meal toy. One is having regular exercise. We don't have to be marathon runners, but do something, as Cathy was talking about. And the third one is our faith. And we know people whose life is a little difficult because they're trying to balance on 2 legs. People whose life is all over the place are doing it on 1 leg. And then if you're like me, every now and then you bump into someone you know sitting on the floor cursing, guess who? And part of me wants to go loser and quickly run that way before they notice me. But that's not how we were brought up. We're brought up by coming over and putting our hand on helping the other person up. Not her, no, I'm teasing. Because the person who might be on the floor tomorrow might be me. If we work together in this, you know, as MS News and Views is proof of, we can really make a difference for everyone. Is there a diet that changes MS per se? We want some people not to simply, like we're a country where we're overfed, undernourished. The one thing all nutritionists agree on, the best way to get your nutrients is in your food. We're a country that's sort of like the main place we cook is in a microwave or in a fast food bag. More than a fourth of the people buy at least one meal a day in a fast food restaurant. Quite a few twice a day. It's inexpensive and it's convenient, and I'm loving it.
I just had a question. I've had several health issues. I've got MS. I've had it for over 15 years. I've had breast cancer. I've got thyroid disease. With the thyroid disease, obviously, the Lemtrada wouldn't work for me. Are they looking into anything else like that for people that have thyroid issues?
So if you had thyroid issues, it does not mean you couldn't take Lemtrada. I mean, if your thyroid is underactive or overactive, Lemtrada is not going to affect it at all because you already have a thyroid issue. So people can take Lemtrada even if they have thyroid problems. Thyroid problems are 3.5 times more common in the general population. But having thyroid problems is not a reason why not. I mean, if your thyroid was low, I can pretty much guarantee you wouldn't have a thyroid problem from Lemtrada because it doesn't cause your thyroid to become overactive. It's already sort of not working.
When you have leg rigidity, what's the normal length of time that it lasts on average?
So many people with spasticity, it sort of goes on forever. I mean, as Cathy mentioned, there are 4 seasons to MS. Heat, summer, fatigue, spring and fall tends to be relapse season because it's flu season, although that could happen any time of year. But when it's cold and blowy and wet, spasticity is worse. Spasticity takes many forms, anything from inability to bend the leg if one can't walk at all, to just an occasional Charlie horse or cramp. A cramp, we all know, may last just seconds or minutes. But some people have spasticity, I'll meet, that haven't moved their legs for years. Again, the best treatment for any MS symptom, please don't forget, is to not get it in the first place and be proactive.
Okay, thank you.
Next.
And also, how long it might last is until you finally get a medication or exercise program to treat it.
What is your prediction about the future of stem cell therapies?
So stem cell therapies are interesting. We've been able to do stem cell therapies effectively in other animals. And those of you who were at the MS Research Symposium several years ago showed that we can do it in mice. The problem you can't really do it in humans. The reason why is nerve cells don't grow much in adults. It's the glial cells, the supportive cells. If they grow too much, then you get a glioblastoma, the most rapidly growing brain tumor, or tumor of any kind. There's a lot of just, unfortunately, restrictions in its use. We know if we do stem cells, that some cells will go into the brain. There's just no question about that. The question is, can you get enough of them there to provide a meaningful difference? Lemtrada, elotuzumab, was used for many years at Northwestern in the stem cell program there as a conditioning agent so you could give stem cells. The problem is, let's just say I had a big jar of stem cells here for you. You didn't know that. That was one of the things that we're having the drawing for, stem cells. And I just gave them into you. Your body would kill them in 5 minutes because they would be recognized as foreign. So we have to give very strong immunosuppressive therapy. Right now at Northwestern, they use a combination of Cytoxan, anti-lymphocyte globulin. In most countries, they also give methylene, otherwise known as nitrogen mustard also, and just really completely obliterate a person's immune system. Cytoxan was initially studied 27 years ago, but the problem is it kills all the cells that later make myelin. So, there's a lot of work yet to be done on it. But again, in the same way, like certain illnesses are linear, building a bridge is kind of linear. Discoveries in medicine, we kept bumping against the answers, the questions, the problems, and boom, like the answer's suddenly there. It's not predictable. That's why the research is addicting to be part of. So I don't know the answer when it'll be available, but in some ways, some of the therapies we have, the T-cell vaccine study, and there are other T-cell vaccine studies that are being done as well. Studies to rebuild myelin, studies, the use of now an FDA-approved drug like Lemtrada is like one step beyond stem cells in some ways.
Your prediction, what do you think as a betting person? Do you think the future is going to be along those lines, or it's going to be a pharmaceutical advancement?
Repeat his question, please.
The question is, as a betting man, would I bet it's going to be stem cells or one of the other, like pills, shots, IVs, et cetera? I think stem cells may come into more wild use, but probably not for more than a decade. The main area we're doing stem cell research is in type 1 diabetes. Type 1 diabetes, pancreatic cells don't make insulin, but if you put a growth in there, well, if it gets too big, you cut it out, or you can give drugs to block the insulin. The problem is brain tumors don't kill people by spreading to other organs like lung cancer does. It does by mushing our brain. And that's one of the things that makes it difficult. You can't like put a second brain in here. I'm from a big family, as many people know. There are lots of twins. It's okay, I'm not a twin. But sometimes I joke, maybe I was an identical twin. My mother stuck my brother Jimmy in the freezer in case I needed spare parts later. And oh my gosh, you know, I hit my head too hard on the table, or I got a mess, whatever. Don't worry, we're gonna thaw Jimmy and squirt him in. The problem is, even if you could do that, that brain you'd put into me, it wouldn't work because Jimmy's been in the freezer all these years. Because brains have to be trained. Just having tissue there by itself alone isn't sufficient.
Next question's over here.
It's actually a three-part question. So I was going to ask about Lemtrada, Aubagio, and the vaccine that you were talking about. I'm excited about the vaccine. That'd be great. But the Lemtrada and the Aubagio is a pill. Does it show any kind of indication that it would help to promote myelin regrowth? Does Lemtrada?
No.
No. Okay, that's easy.
The question is, do the drugs do this, or are you doing this? Right. MS is different in everybody, just like, I mean, strep throat's the same in pretty much everybody, but MS is not. And certain genetic targets we're studying are how come some people remyelinate more effectively than others? How come some people's MS is so much rapidly devastating, have so many more MRI lesions, or those dark spots, so-called T1 black holes, hypointense lesions on MRI scan? Why is MS different, you know, in Caucasians versus non-Caucasians? Some of this may be due to different ability to remyelinate. I mean, if we can find a couple of genes that just trigger remyelination, it's over. It might be the cause of MS you can't block. I mean, we can't keep people, as an example, from getting strep throat, but it doesn't matter as much since we have antibiotics. It might be the cause of MS is also something we can't make go away. These crazy teenagers in Mars programming evil beams towards the planet. But if we find a drug that stops the disease, those teenagers will go on to a new game.
Over this way.
This seems to be a lot of Lemtrada talk, and I have another question. I understand it's 5 days of infusions. What other precautions are there after those 5 days?
So, you know, this isn't meant to be a Lemtrada talk. People ask me questions about that. People get a blood test once a month for looking at their, blood counts. Doesn't make people anemic, but, they're a little less than 2% of people platelet count decreased. If that happened, we just give them a little bit of oral prednisone or IVIG. A rare person might need a drug called Rituxan. But the side effects of it, let's say, if you just look at the total side effects of Lemtrada versus, let's say, getting PML and Sabri, the side effects of Lemtrada, from thyroid to kidney to blood counts, what have you, they're all very easily treated. The problem with PML is there's no treatment, which is why still, even though this has been seen now for more than 10 years, people are still dying of PML. Now, not everyone does. If people get caught quickly, before they're symptomatic, they may do quite well. The problem is, there's no drug that reverses PML. And PML is not just seen with the separate. I mean, it's seen in our HIV population of patients, certain advanced leukemia patients as well. It's a huge problem. It's been studied extensively. And actually, if people want to know more details about PML, Joe Berger, who was the chairman at the University of Kentucky in Lexington, who's now the chairman in Pennsylvania, he's going to be our guest speaker here in Chicago at the MS Research Symposium. And he was very excited to come. So Joe always said that, like myself, he was a virologist. He said he was the world's expert in the disease, that until December, no one cared about PML. So you can learn more about that then too.
Cathy, are probiotics, do they really work?
Boy, that's a good question. Do probiotics really work? I don't know if I know the answer to that. I know that we talk a lot about probiotics as a way of managing colon health and as a treatment for bowel health. I go back to foods and hydration. Keep it simple is kind of my suggestion to everybody who comes. I don't prescribe medications. The medications I suggest, multiple vitamin every day, because nobody has the perfect diet. Vitamin C to promote bladder health, 500 milligrams in the morning, 500 milligrams in the afternoon. And watch your food groups. Look at the American Dietary Association website. Remember that pyramid they taught us all when we were going to school years and years ago? The food pyramid, keeping fats at the top, the minimal. That's not broken. We have a lot of new and wonderful suggestions in the world, but the old ones aren't broken either. Healthy diet. Go to the American Dietary Association. Adequate hydration. And again, a couple of simple vitamins. You have to be careful with supplements and with vitamins. We sometimes think over-the-counter can't possibly be dangerous. It can.
We actually have seen slews of patients come in who've been given very high doses of vitamin D and now are getting kidney and bladder stones. It's been a big problem, that's become new. So take vitamin D, that's okay, but don't go overboard on that. Probiotics are useful for replacing healthy bacteria in your gut because many people are being given Cipro, Levaquin, Avelox. Those drugs napalm the healthy bacteria in your gut. They also stimulate a chemical called tumor necrosis factor alpha. Barry Arneson here in Chicago has published extensively showing that actually may make MS worse. If you take a probiotic, though, take it when you eat. Because if you take probiotics on an empty stomach, the acid in your stomach will destroy the bacteria in the probiotic. I mean, I was once a 3-year-old boy, and I did what all 3-year-old boys do, hammer sticks on the ground and eat mud. There's a lot of bacteria in mud. Why am I still here? Because there's acid in my stomach, killed the bacteria in the mud that I ate. I know it's stupid, I ate mud, but all boys do. You played with girls, don't laugh at me. I cut off the doll's hairs on my sister's doll, so that was okay. But if you take a probiotic, take it with food, that way it'll work.
This direction.
Living in Illinois, we now have legalized marijuana. What is your viewpoint on the feasibility of using marijuana as a treatment for MS?
Outside the United States, people use cannabis for many symptoms of MS. In most countries, it's not illegal. The symptoms that it seems to help are spasticity, pain, anxiety, and sleep. The symptoms it makes worse are cognitive function, balance, and fatigue. Again, if you work, don't use an e-cigarette with hash oil in before you have your job evaluation. That actually might not work, even though you are anxious. I may be on the state committee about this. There are a lot of problems with the adoption of the law in Illinois versus other states. Off camera, I'll be happy to tell you more details about that.
I heard you mention mung, and I was wondering, is there a blood test for that? How is that treated?
So, what was the thing? Mung?
Mung?
N-M-O?
No, I thought it's M-O-N-G.
I'm sorry, I'm not sure what.
Oh, okay.
Questions?
I am an Olympic quality mumbler. I apologize.
When my wife was diagnosed with MS, her doctor initially said, "Oh, you're too old to have it." Now I've been reading lately about children being diagnosed. Can you talk to that at all?
Sure. The question is, my wife was diagnosed with MS. She was told she was too old to have it. She must have not read the book. Now I hear children get the disease. Most individuals with MS are diagnosed between 20 and 50, but 3% of people with MS will have had their first symptom before they're 10, and 3% will get diagnosed after 60. The majority of people I see who are diagnosed after 60, taking a long, slow patient history, reviewing old records, I'll find something else. In children who are who have individuals who have the first symptom when they're children, again, often they're not diagnosed because the doctor has to think of the diagnosis to make it. If someone has optic neuritis, people will think about it. But many symptoms not. A lot of early symptoms in us are very nonspecific. I mean, I raised 3 children. Every time my child's leg they complained of my leg is numb or stiff or I have a cramp on my leg, I worried about MS, they would never grown up. And symptoms often go away early in the disease. There are several people I've seen who had strabismus surgery in childhood for double vision, like a lazy eye. Later on, we learned that, and later they had MS, and when you look at their MRI scan, you can see the lesion in their brainstem. They gave them what was felt to really be strabismus, but was really multiple sclerosis. Some people have late in life onset MS. Again, relapse remitting MS, it's not like this. One woman came to see me years ago and said, "Do you treat September multiple sclerosis?" Relapse remitting, second aggressive, primary aggressive. Oh, yeah, September MS, what's that? He said, "Every September I have a relapse." So it doesn't necessarily work that way. It's not like one a year. Some people might have one and literally nothing for 20 years. So one pattern that's described a lot, particularly in Europe, is what's called intermediate MS. These are people who have a cluster of attacks, and then nothing at all happens, not on therapy for maybe even decades. And then suddenly disease becomes progressive. And it would be nice if it was predictable. There's this term called benign MS. I have 2 things to say about that. One, here's my definition of benign MS, somebody else's. The definition of benign MS that's been used is no difficulty walking after 20 years of untreated disease. Well, there are people who were never on disease-modifying therapies in the years before them who could walk fine, but it's a small minority of people. Just like there are many people who live a whole life and never are disabled. They just, as they get older, they suddenly die of a heart attack and they're a second day in their life. My grandfather was like that. But I buy disability insurance. It doesn't make me not get disabled. It actually probably makes me more likely to get disabled because I ski more recklessly. But being on a therapy for MS prevents complications from happening.
My question.
In my opinion, the disease-modifying therapies for MS can be more effective than insulin that's preventing long-term complications from diabetes.
My question, when you're talking about youth with MS, is it, I have read, if you give somebody who is more likely to develop MS because they have a parent or somebody in their family who has MS, give them vitamin D, a higher dose of vitamin D at a younger age, it keeps them from getting MS. Is that correct?
No. There's actually no evidence that giving vitamin D helps almost anything. The disease that's most closely linked to vitamin D is osteoporosis. The average vitamin D in African American is around 14 to 16. In Caucasians, it's 24. Caucasians are the ones who get osteoporosis. African Americans, it's much less common. We know that vitamin D often is low in MS. Is there much evidence that adding vitamin D changes anything? There's one small study in Israel by Anat Ashron, raising the question that maybe it does, a study of less than 30 people. And I know there's a lot of stuff on this. And it's attractive because one thing that was shown for 50 years now, let's say, that MS is less common around the equator. than cooler climates like here. I mean, MS is much more common in Chicago than in Texas or Florida. Other people get it while living here. And some people say, well, it's due to less vitamin D from sun exposure. But the other theory, and the one that, and both might be right, is it's really, when we live in a cooler climate, children are more likely to get exposed to antibiotics at a young age. Like when in a warm climate, they're not likely to get a cold as much. Early exposure to antibiotics stunts the development of the immune system by killing the healthy bacteria in our gut. I mean, the main difference in your DNA and mine isn't that which we got from our parents. It's the DNA and RNA and the bacteria and viruses that live in our gut. They outnumber us 1 trillion to 1.
Doctor, is there an expiration date on MS drug therapies as to how long you can use them, other than after you die?
So we recommend not taking them after life. That would be a good. I mean, most neurologists would generally agree on that. No one agrees on everything, but in general, that's true. The National MS Society recommends that people, as soon as they're diagnosed with MS or have one symptom consistent with MS with an abnormal MRI, meaning even as few as 2 lesions, go on therapy and stay on therapy unless to stay on therapy unless the therapy clearly is not being effective, worsening disability, for example, or the person has a side effect that's intolerable. It might be a side effect the person is not willing to risk getting. Some people say that MS burns out. Well, it just stops. Well, clearly once people are bedbound, they don't walk any worse. But so one wants to always, balance the benefit versus the risk of every therapy, any medicine, for any condition for that matter. It's what are we trying to accomplish here? There was a meeting earlier this year in Taos, New Mexico on neuroinflammation, and one group did a very interesting study. They did special kind of PET scans of the brain, and they scanned people over 80 with MS, 80 years old. These people all had advanced MS and had it for many years. You could see inflammation in the brain in at least 60% of these individuals. These are people whose disease looked like it was, quote, burnt out, not getting worse, but there was still active destruction. Now that said, so that was the bad part of that, and that's why many people continue therapies for long term in people. But the other thing is that there's always remyelination occurring. The question is, can we make the remyelination work enough to get you more function back? And that's again why people try to slow the disease down. In general, the older person is, regardless of the onset of the disease, the less frequent flare-ups are. In my observation, that of many others, as one gets older, however, if one has a relapse, it's less likely to go away. Like I see a perfectly healthy man who at age 85 has a big stroke, but was really never sick a day in his life up until that point. I've never seen one say to me, I'm totally stroked out right now, but I've been good up to this point, so it's really okay. It's never okay. It's never a good day to be sick. Unless you're on the, Nashville Predators, they can be sick for at least, a few more games.
Thank you, Dr. Wynn. That was actually the last question, Dr. Wynn?
Yes, that was the last question. So I want to thank both of these persons. I'd like to thank them both very much, and they delayed a trip to Washington, D.C., where they are going with, like the rest of the neurologic world, for the next 5 days, I believe. They're going to the American Association of Neurology. Why? So they can learn to bring back new information that will benefit all of us. So I want to thank them for sticking around today to do this.
And I think we should encourage Stuart to come back and return again and bring us all together. So thank you.
We got to get another person to run around the room with me. I lost a pound.
Thank you.
Last year we did 40 programs in 52 weeks, right? This year we wanted to cut it back a little bit, maybe do 35 programs in the same, or this year's 52 weeks. But right now we're showing that we might get up to 42 programs this year. And we still have a lot of other grants pending. So again, it just means that we're trying to provide you all with the information that, again, is coming from me, the organization, this person down there, Jill is her name. She does a lot of help with us on our programs, and the rest of the MS Views and News team. And again, I want to thank you all for being here today. It's full house, and thank you.